Hello, Badal.
Hello. Yeah, good afternoon. Good afternoon, sir.
Yeah, good afternoon. Good afternoon. Hello, Dr. Amit. Hello. Hello, Dr. Yadu. Badal, I have prepared a cover slide for the workshop.
Okay, sir. Then I will make you the presenter.
If you make me the presenter, then I will not be able to see anyone. Is that the case?
No, sir. You can.
Okay. Hi, Dr. Amit. You're muted. You're muted.
Right. Better now?
Yes. Sir.
Oh, great. I want to check if I can share my slides. So just we'll try that out.
Yeah. There is a lot of headspace. So if you could reduce that.
All right, all right. Come closer, you mean. Come closer. Okay.
This is good.
I like that word, headspace. Yeah.
Right. So, Dr. Badal, if you could make us the co-hosts, we'll try and see if we could share our screens or not.
Okay, sir.
Amit, I do not have your slides. You have it, right?
I have my slides. Yeah. How do I go back? Okay. This must be it. Share content. Wait. No, the share is not open up. Is it? Let me get some earphones. Maybe it's better. I don't know. Hold on.
No, it's fantastic. Your voice is very clear.
Okay.
So you also have access
Still
to
can't share my slides. Oh,
you also have access to our WhatsApp group, right?
Yeah, I do.
Because if we need to communicate among ourselves, maybe we can do that on this WhatsApp group as well.
I need to know that you're saying something.
Yes,
I
sir.
still
I have
can't
made
share.
both of you co-host.
Really? But I still can't share.
Okay. Now you can try, sir. I guess I have made
I tried.
both of you.
The share option is still in watermarked.
Yes, sir.
Maybe it takes some
Okay.
time.
It is. Yes, sir.
Okay, now you're co-host. Okay. Not happened as yet, but last time it took some time.
Shall I make you the presenter, sir? Then.
Yeah, I do that because I can't. It's not
Yeah.
coming up.
Yeah. Yes, sir. Now it will.
Yes, now it's there, and I can search Microsoft. Okay. Is that clear?
Yes, sir. It is.
Perfect.
It is clear.
Okay. So just to give you, I just initially just a very brief introduction and a little bit about the program. So, next, we'll end up with the need to bridge the gap type. So then is the group work session. You'll be having your videos and all that kind of stuff in between. And then I come back for the group work and introduce the group work. And in the group work, I'll be talking about the various group and give them a little bit insight into what it is. So, before dementia, I'll tell them what dementia is. They should not be totally lost. Before depression, I'll tell them what depression is. And before integrated care, I'll tell them what integrated care is all about. And then they go for the group work. And then they come back and we talk about the various guidelines and work that we do. Yeah?
Perfect. Looks very good.
Yep.
Anything in particular that you want me to emphasize during the third group work?
No, just don't worry. Let them look at the casework there and try to focus on improving functional ability. Otherwise, if you try to do everything, you try to do palliative care, you may just go in that angle. But here, the whole focus is about trying to promote healthy aging, try to make people functional as much as possible.
Yes.
And so let's try to see what all things we can do on various of those on various domains to be able to keep people functional. I come in the okay. I'll see how I can do that actually, because I'll be needed in the group also. But I will come in groups as well, so just to make sure that if they need any help, always.
Shall I also share my slide layout?
Yeah, you can do that. How do I put this off?
Yeah.
I have to go off, is it?
No, you have to stop sharing.
Yeah, where is that? How do I get back? Where am I? Where is stop sharing option?
Can you press the escape button?
Okay, I'll do that. I did press.
Doesn't work.
Oh,
If you take to Dr. Badal, could you please guide how to stop sharing?
sure.
Sir,
Sure.
is there a option at the bottom, sir, in the share
No,
column?
see, my thing is that I can see the presentation here and the video, the WebEx thing has become very small. How do I increase that? I don't seem to see any options with it.
If you take your cursor to the top of your screen, like the center top, do you get something floating?
I've done some strange. No, this is not working. Take the cursor to the center, this on top.
No ribbon.
Stop. Yes, on top there is something shared and there is a stop. Now it says stop. Correct. You're there, right? Stop sharing. I've done that.
Perfect.
Oh, it's a good thing we tried. I won't be able to stop sharing.
Right now I can't share. Dr. Badal, you
You make the presenter. Being the co-host, you can't share. You need to be a presenter to be able to.
Presenter only.
Yeah, so back to Badal.
Badal, can I forward my slides to you in case you want to put the cover?
I will make you the presenter, sir.
Okay. Yeah, I am the presenter, it seems. Is my screen visible?
Yep. Yeah. Perfect. Very nice.
So I have made a cover slide so we can put it whenever we want. And
yes.
So we start after the initial formalities that we have, introduction, and then going through the responses. Then we get started with Nora's video. Okay. So here we have. What is it?
Hello. I'm on the workshop. Yeah, fine. Yeah, bye. Call me. Yeah, I'll send you the number. Yeah, bye.
Nora's video is not playing. Should be prepared for it. It doesn't play.
Doesn't play, is it?
No.
You put it in the thing.
I put it in. It doesn't play. I'll come to my browser and see if it works. Okay. On the browser, it works. Did you get the audio?
Yeah, just play it a bit.
In Ireland, as in many other countries, we are living longer and better lives. This means we have to make changes now to ensure we can provide well-planned, well-coordinated care for older people when and where they need it. This is Nora's story.
All fine? This one goes
Yep.
well? Yep. Okay. So we have Nora's video and then this one. And the WHO video also needs to be played. Okay, so the WHO video is also playing. The SRT video needs to play now. When we are sharing, it doesn't play.
Mm-hmm.
Yeah. Figure out the SRT video.
Straight from there.
Hello, Dr. Aksman. Hello, Dr. S.
Hi.
My name is Dan Reinen with WeBeFit.com.
Fadal, is this
And this
working?
is a sitting rising test to help determine how long you might live.
Dr. Ashwini, is this?
To prepare,
Are you getting the
get
audio?
into some comfortable clothes, remove any shoes.
Okay. The audio and the video also. Great. Close the unnecessary tabs.
Anil, you have a question today? Or Anil?
Hello. Yes, sir. Hello.
No, I guess he's calling out for someone else.
No. There's nothing together.
Archis, what about
Yeah.
the breakup? Have you made the groups?
No, we have not made any group.
Yeah, I think we can just probably do that before.
Dr. Badal, is there a way we could make the groups? Like,
Yes, sir. There are more options. There's three dots in we can breakout.
yeah, but how do we identify who goes into which session?
There are anyways, sir. We can do it manually also.
Okay.
So could you just do it now in advance, Badal? I would say try to put a different state together. Don't put people from the same college together.
I think it won't be possible now. Before we had started the meeting, we could have done that. But now that the meeting has started, pre-assigning will not be possible.
Okay.
No. So what will happen about the groups?
So whenever we start the breakout groups, Badal will have to either manually assign them or we create
So
more
keep
breakout
the
sessions.
manual assignment with you ready, Badal. You
Yeah.
get what I'm saying? Keep your manual assignment. So you can say A, B, C, D goes into group A that way. Okay. So what I'm saying, when you're doing the manual assignment, don't try not to put people from the same college together. That's all.
Okay, sir. I will try that.
Yep.
I guess we have the session plan with us. Hi, Dr. Ranjan.
Hi, Ranjan. I can't.
Hello, ma'am. How are you?
You're muted. You're
Ma'am,
muted.
you're muted. Your microphone is muted, ma'am. Badal, could you make me a co-host?
Hi, Dr. Biplab, Dr. Vinita, Dr. Pratyaksha, Dennam, Dr. Yadu.
Hi, everyone. It's nice to see you earlier in.
Hi.
Yeah.
Hi, sir.
So have you all filled out the Google form yet?
Sir, I filled it.
Thank you. Thank you, Dr. Biplab. Dr. Vinita? Have you filled out the Google form? Yes.
Archie, I resend my PPTs to you.
Okay.
Did you get that? Because I edited few slides in those presentations. So
Okay.
did you
Just
get
recently.
that?
Just recently you said.
Yes. 10 minutes back, I think.
10 minutes. I haven't checked.
Okay.
You want
So
me
if I
to?
had to share, yeah, if I had to share the content, I just have to click on the share content and open my file, no? That's
Yes.
it, no?
Yes, that's all.
Okay. Shall I try right now?
Yes, please.
Yeah, all of us have tried.
Yeah, can I do it now?
I will have to make you a presenter, ma'am. Please hold.
Yes, okay.
Yeah, I think you should be able to do that now.
Okay. I think desktop I'm not able to see.
So a small icon will be on top of everything.
Yeah, got it.
Yeah, inside that you'll get a share button.
Yes.
So click on that.
Yeah. I think that's happened.
Is the share button gray or is it clickable?
Blue.
Yeah,
It is clickable.
Yeah, we are seeing your screen now.
Mm-hmm.
You've shared your Spotify app only.
I was trying to figure out what this is actually.
So, Ranjan ma'am, you will have to unshare again and share your PowerPoint application. What you have shared is Spotify application. So we can see your music library now.
Okay.
Quite good choice.
This is not mine.
I took a while to take my eyes off that motorcycle. It was really good.
It's not my collection, it's my niece collection, I think.
Okay. Great bikes.
How to get out of this?
Yeah, I have to.
Now you can
on the right corner on top, you'll see something.
Right
now
corner.
when you click on share, you'll see a array of things that you can share. So it can be your entire screen or it can be just a specific application. So you can just share your PowerPoint and only the PowerPoint will be shared.
So share a file and then this aging with grace. So continue. Yeah, I think it has come. Yeah. So
Yes.
are you able to see this?
Yes.
Okay.
Yes.
Fine. So how to get out of this? Like how to,
Now
if I want to.
there's a bar on the top.
Yeah.
Which will have an option to stop sharing.
Close the content. Close content tab.
Yes.
Okay. It's saying, do you want to save the current document? Yes.
Yeah, now it's gone.
Okay. So I think it will be fine if someone else, if I send it to someone
Okay.
else. And
Yeah. Badal, could you present for ma'am?
yeah. Yes.
Ma'am, if you could send it to me or to Badal, if you have his email address, we'll present it for you.
I can also operate as a backup because I have the slides.
Okay.
Ashwini, I have forwarded these presentations to you.
Okay, ma'am.
Sure, shall we start if all of them have joined?
Ma'am, I think we're still waiting for a few of them, yeah.
Okay, okay.
So as we start, Biplab, Badal, could you please make me the host? I want to put up the banner.
Before that, Ajasmant, I will have to introduce you. So I'll just do that and then give you the presentation rights. Yeah.
Okay.
Badal, could you send a message in the WhatsApp group urging people to join?
Yes, sir.
Ranjan, your email does not have attachments. आपके email में attachments नहीं थे.
I'll check.
We have someone with the name Acer2. Is that one of the organizers or it's a participant?
No, I think it is one of the participants.
Yes, sir.
Did you get it, Ashwini?
I'll check again. Yes, ma'am, got it. So, Badal, I'm forwarding you Ranjan ma'am's presentation. So whenever she asks, you will have to present for her.
Okay, sir. Okay, sir.
Ranjan ma'am, please just say next slide whenever you want the slides to be changed. Amit, you look very different from the last time we had met. We had met in the telemedicine workshop in Bombay.
Okay. I do look different. Yeah. Yeah. I didn't realize that. So let us know when we have to start.
I think we'll be waiting for a few participants to join.
Okay.
So meanwhile, if any of the participants who have already joined have not yet filled out the form, please type in. It doesn't take any time. You can access it on the WhatsApp group so that we can have a representation of your expectations from this workshop. Dr. Abhilasha, have you filled out that form?
Sir, I'm going to fill it just now. I'm just doing.
Okay, thank you. Dr. Amay, have you also filled it out?
Should we wait or should we start? A few more participants will probably join.
I think we should start.
Yeah.
It's almost 15 past 2.
Yeah.
We should start.
Yes, ma'am. So on behalf of the organizing team, I would like to welcome you all to this workshop on the leadership in integrated care of the elderly. I would like to welcome the faculties for this workshop. First, we have Dr. Amit Dias, who is an assistant professor in the Goa Medical College. His areas of interest are epidemiology, geriatric medicine, and infectious diseases. And he has a madrid of achievements to his name. He's been awarded many international prizes. He's at the administrative lead of multiple societies, and he stays at the forefront of public health and we couldn't find a better person to facilitate this workshop. We have Dr. Achman Mohapatra, who is the Executive Director of Grid Council. His interests also lie in epidemiology, public health research, and educational research and leadership. He's also received Indo-Canadian Research Scholarship. He's got recognition from the Director of ILBS and from the President of IAPSM. He's had multiple research grants and conference awards to his name. We have Dr. Ranjan Solanki, who is also a part of the extended MGIMS family. She's currently the Associate Professor at AIIMS Nagpur. Her interests also lie in mental health, geriatric health, and we personally couldn't have had a better person. We've seen Ranjan ma'am being passionate about mental health, geriatric health, and she is one of the best persons to talk about in such a workshop. So I welcome all three of you, and the stage is all yours.
Great. Can I share my slides? Can I share my slides, Badar?
Yes, sir. I'm making you the work.
Yeah.
I've made you the presenter. I think you should be able to share.
It's taking some time. Yeah. Yes, now.
So we're going for a introduction of the participants as well, right?
Yes. I'll just briefly introduce probably the what this is all about. So welcome everyone, and thanks for the wonderful introduction. It's always a pleasure to be on a platform like this. Yeah, it's not a platform. I would have preferred to be face to face though. But thanks to Abhishek and the wonderful work that all of you are doing as the young leaders in the IAPSM and brought this whole workshop together. And I've been keeping track of how it's working. Now, what I intend to speak to you in this workshop is just to try and help you understand how we took a leadership role in this strange topic of older people. And not many people, 20 years ago, were trying to, were showing any interest in working. What you will try to understand is I started off doing this as part of my thesis for my MD in community medicine. And when I joined community medicine, I was not very happy about joining community medicine. I wanted to be a surgeon always. And so I challenged myself with something very challenging that was, I said, do some very rare topic, and that was Alzheimer's disease. And honestly, at that point in time, I didn't know much about Alzheimer's disease. I had not even seen a case of Alzheimer's disease during our MBBS time, and I don't know how it is with you all. But when I went to the community on day 2 of joining the department, I found that there were a lot of people with dementia. I found that it was a major public health problem, and it was palpable in the state of Goa. So I had to do something for it, and that's how I started off with my research, but being led to another. And you need to understand you're doing research not only to publish a paper, but you're doing research to be able to address the need. And how this was done and what was my journey is what I'll try to explain to you. What I will try to do as well during this workshop is to give you an opportunity to rethink the whole thing. We'll give you the scenarios in your group work, and you can come up with ways and take the lead in trying to address the problems that we will be giving you. So welcome again, and greetings from Goa, lovely place. I don't know how many of you would have probably come here, but a chill out place. Healthcare facilities are very good, and so people are living longer, which is a very good thing. But the problems associated with older people are also kind of very palpable in the state of and so it becomes better to have services for older people and be prepared for what's going to come in the near future. So the WHO is very clear on this. We're trying to promote active aging, and we want to add life to years. This is not years and years and but we want to ensure that the quality of life is good. But with aging comes that is one thing leads to another. For example, if you have diabetes and depression, you'll understand that diabetes will worsen the depression will worsen the management of diabetes. This will lead to poor care. It impacts the person's capacity, it impacts healthcare, it impacts healthcare utilization, it impacts the cost. We need to do something, and we need to intervene early such that this does not happen. The long-term care needs are also increasing, and our care capacity is decreasing. So with families becoming smaller, we have joint family system. Women have a different role, which is a very progressive thing to happen. But traditionally, women would take care of the older people in the family, and this is not happening. As a result of which, older people do not have people to take care of them. In an environment like this that is changing, how do we bring about change? The whole focus of this discussion and in this workshop is going to be how we can improve primary healthcare. Because if you talk about geriatrics and integrated care for older people, it's a vast topic. It's like talking on how we can improve pediatric care. It's similar to that, but we will be trying to see how we can improve things at the primary healthcare setting itself, which is where we would be working, and how we can build capacity. Everyone wants to live long, but no one wants to grow old. And this is we need to see why they don't want to grow old. And if people are growing old, we want to ensure that they grow old and age gracefully. And that's what the whole crux is going to be all about. So with this kind of introduction, I would like to know from each one of you, give you some time to actually introduce yourselves. That'd be nice. So, would you like to introduce yourself? How would you?
Hello. Are you asking what the participants to introduce?
Yes, I'm introduce the participants.
So let me take the first call. I'm Dr. Prakash Kansal. I did my MD way back in 2000 from Patiala in community medicine only. And thanks for the organizing team for such a nice platform. The intent for me to undertake this workshop is basically that I am also seeing myself 10 years down the line supporting the geriatric population significantly. Because I have a lot of passion and empathy towards that age group, and I understand the challenges which are going to be there. I recently also attended the PHFI led clinical geriatric medicine course as well. So this workshop which I saw on the website is an icing on the cake for me to understand little more. And I'm very happy that you all have, despite being from community medicine, have taken the off-route path. Hopefully, I will also learn and follow you sometime later. Thank you so much.
Sure. Excellent. Next.
Maybe Dr. Kansal can nominate another participant for the introduction.
Hello, sir.
Yes.
I'm Dr. Bodhishri Vidya. I'm Associate Professor of Community Medicine. I'm from Andhra Pradesh, Visakhapatnam. So I'm very I'm eagerly waiting to listen this important element of geriatric care. How you people are doing very you people are having very rich experiences. I want to see how much you are having that, and actually we are at very nascent stage to start in these things. That's all, sir. But sorry for that. I have to log out for 5 minutes because I am at my kid's school. I have to receive my son. 5 minutes.
Okay.
I will get back again, sir. Please consider it.
Sure.
Thank you, sir.
Good afternoon. I'm Dr. Aishwarya from Bangalore. Can I continue?
Yes.
Yes.
Yeah. Okay. I'm an assistant professor in the Department of Community Medicine. I'm also in charge of the Rural Health Center. So most of the cases that we see in the OPDs, 90% of them are elderly. So the integrated care will really help me in reaching out to them and provide better services. Our college is also tied up with Unnat Bharat Abhiyan. So through that, I would like to take elderly care forward.
Excellent.
Good afternoon, everyone.
Good afternoon.
I'm Dr. Yogita Bavaskar. I'm Associate Professor in Department of Community Medicine at Government Medical College, Jalgaon. I am attending this workshop because I feel geriatric is an important sector where work needs to be done. And I like to work in this field. And secondly, I'm attending this workshop because Dr. Ranjan is my batchmate. So I just wanted to listen to her. Thank you.
Great.
Thank you, Rita.
Right. So could Dr. Biplab introduce yourself, please?
Okay. Good afternoon. Dr. Biplab, junior resident at St. Medical College at KM Hospital, Mumbai. We have a geriatric clinic in our that comes under our area. So, pretty interested in knowing about how to take care of the elderly because it is a very different thing as compared to the other age groups. Thank you.
Perfect. So if others could quickly introduce themselves, we could get into our proceedings.
Good afternoon, sir. So I'm Dr. Abhinasha. I'm from University College of Medical. Anyways, they're aging, so I absolutely disagree with that. And I developed the interest, and that's why I'm here to learn more about it.
Excellent. Next.
Hello, good afternoon, sir. So can I continue?
Yes, yes.
Yes, so this is Dr. Pratyaksha Pandit. I am junior resident first year in Community Medicine Department of King George Medical University, Lucknow. So I am also interested in geriatric health, and as the world's population is aging towards above 60 years, so yeah, I want to learn about that also. Thank you.
Next.
Dr. Amit, we can go to those Google Forms because that also has a representation of what
Yes,
kind of
I think we will do that. Excellent. I think we should go to that because this is.
Yeah. So if you could stop sharing, I can share my screen.
I will do that. I have done.
Yeah. Dr. Badal, can you please make me the presenter? Yeah, thank you.
Yes, sir. Sir, now you can present.
Okay. So thank you everyone for filling out the Google form. Once again, welcome. We had received 16 responses. I guess it continues to 17. I saw at one point of time. 16 only, yeah. So quite an interesting mix of audience. We have people, majority is junior resident, MD, pursuing MD or PhD, but we also have some seniors joining in, and also mid-career, early career. Age band is also reflective of that only. A fairly good mix of gender, balanced one. This is quite interesting to see the expectations. So better understanding of elderly care, what kind of challenges they face, what opportunities and challenges do programs provide, and how to overcome the challenges, what tactics we need to handle geriatric care, and how to plan integrated care in our community settings. Palliative care, how to go and help out, how to manage geriatric problems in home environment, integrated care, and that encompasses all your activities of daily living as well. What skills we need and how do we understand the needs of the community using different methods, how to take care of health related issues, what is the future of geriatric medicine and what role public health professionals can play, what is the applicability of geriatric medicine in community settings and routine healthcare, idea of a leader to elderly. So that's an interesting query. And role of MD Community Medicine as a leader for the provision of healthcare services for the elderly. So quite a variety of expectations. And what skills do you think you need? Communication, patience and compassion, ability to organize and plan. Again, communication, patience, sensitivity, time management, need assessment and evidence-based decision making, punctuality, humility, empathy, experience in clinical care, resource management, knowledge, determination, team effort, patience, physiotherapy, managing depression, clinical skills, leadership skills, communication skills, compassion, communication, sensitivity, finding feasible solutions, compassion, patience, and lateral thinking, passion, subject knowledge, empathy, resource mobilization or availability, man management skills, information with clarity, sympathy, communication. So it's a mix of soft skills, hard skills, managerial skills, personal development skills, and a variety of expectations. So fantastic responses. Thank you so much. This helped us in designing our presentations today. And we hope that during today's session, we'll touch upon most of these. But of course, 3 hours are inadequate to talk in depth about communication and other soft skills. We'll try our best to touch upon these. So over to you, Dr. Amit, for the first presentation.
Okay, so make me the presenter, Badal.
Yeah. So we have lined up. Do we get an outline of the session today? So to give a heads up, what we have is we will try and sensitize you to the priority areas, the challenges of geriatric medicine. That will include different aspects of care as well as other aspects of domestic violence and all. We will talk a bit about why leadership is important in this kind of a context. We'll have 3 case scenarios. We'll have breakout sessions where we'll be dividing ourselves into 3 different batches, and we'll take up 3 different types of cases, prepare a short PPT, maybe 1 slide PPT, come back, present that, we'll have an open house discussion. Then we'll talk about different concepts of aging gracefully, some aspects of leadership, and of course, some lived experience managing different projects. Please treat this as a very interactive session. Please open up, because we see that you have some experience or some aspiration in geriatric medicine. So please open up. Let it be a co-learning session, and we'll all share whatever experiences we have around integrated care for the elderly. Over to you, Amit sir.
Thank you, Dr. Ageis. So as I was saying, this is the Rural Health and Training Center at Mandur. This is the primary healthcare center that is under the Goa Medical College. And till last month, I was in charge of this center. But now I'm full-time at the medical college at the GMC. I was part of other NGOs as I was introduced, like I was the chairperson of Sangat, which is an NGO for people with mental health problems. And I had started the Dementia Society of Goa many years ago, and kind of it was because there was a felt need for additional work for people with dementia that was not being catered to by the existing health system at that point of time. But my primary goal is try to enhance the capacity of the existing healthcare services to be able to cater to the needs. So why should we focus on geriatric health? If that's the question, I think the very fact that you have joined this workshop, it means that you have understood that there is a need for increasing a focus on geriatric health. You know, the population of India is rising, and the fastest growing segment in that population is the aging population. We know that people, if you look at the low and middle income country, the aging population is going to be rising the fastest. If you look at the dark red part, it just tells you very clearly, because life expectancy in a country like ours will shoot up with the increase with all the healthcare facilities that's improving at a tremendous speed. Now, this is a good thing, but it's important for us to understand how the demographics, because it's at one end, the number of older people are increasing. At the other end, the care arrangements for people who are growing old and having comorbidities is decreasing. Our capacity to be able to take care of them is decreasing. In fact, in China, you'll have the kind of system where you have one person looking after his two elderly parents who are in turn looking after their parents as well. So it is 1:2:4. So that is kind of the system that, so one person is actually looking after 6 people, which sometimes it does become, it is something that needs to be addressed. We just can't have a law to say that you are supposed to look after everybody, but we need to also be able to build the capacity and help the person look after the older people. Definition of older people, there are various definitions. There are some agencies that will take the cutoff at 65, and some will take it about 60. But 60 to 69, among them itself, there is a breakup, and you'll have older people who are also caregivers of their older people in the house. So you will have the young old, which is 60 to 69, the old, which is 70 to 79, and 80 and above, which will be called the very old. And you kind of have this, sometimes people are getting confused about what is this geriatrics and gerontology, and the medical study of aging and the process and policy, etc., would be gerontology. And what we are focusing on here is geriatrics and the study of disease that affects the elderly. But you cannot speak about geriatrics standalone. It's not only speak about disease. It cannot be a disease-focused approach. It has to be a person-centered approach. And this is kind of the thing we'll try to drive in throughout. When you're talking about integrated care, you have to think of trying to understand the concept of person-centered approach. Life expectancy at birth. Now, this is something that I put only during your kind of age and period. You can see visibly during our lifetime itself, we have seen that the life expectancy is increasing, and this is going to increase much more rapidly further on. The total number of older people in India itself has gone more than 100 million, and the numbers are increasing. 2050, there are various projections for this. More than around 300 million people would be above the age of 60, which definitely means that we need to have better infrastructure, better capacity at every level of healthcare. It's not only the primary level. We're talking about the primary level because that's usually missed out. And we try to focus a lot on the tertiary level and try to enhance capacity at tertiary level. But we need to improve primary level because the focus should be on prevention. The focus should be on enhanced capacity, on trying to improve what we call intrinsic capacity. We should also look at the socioeconomic profile of India. We see that 75% of the older people are in rural areas. And this is where the primary health centers are, and therefore they need to be able to cater to the older people. Around 50% are women. Many people are illiterate, and therefore if we are targeting their needs, we need to be able to see how we can do that. A lot of people are still involved in physical labor. They're still below the poverty line, and therefore what kind of care we can provide to them, what can they afford? Because primary health care, at the end of it, you need to understand the essence. It should be something that's affordable. It is something that's essential. It is something that can be provided to them, and it should be accessible to them. So we should be able to get geriatric care also to be able to reach out to these people, because it's only then it will be useful. As I said before, this is me many years ago, and as Ashwini was saying, I look different. I do a little bit. And this is when I was in my first year residency, and I told you from the second day onwards itself, I just wanted to do something challenging to prove myself. And I said, I'll do something on Alzheimer's disease. And I went house to house. And I tell you, every patient taught me, because I didn't know anything about this, but I felt there was such a huge gap as far as the treatment gap was kind of huge. And it was like they were desperately asking for help, and our healthcare system didn't even know they exist. Like, honestly, I tell you, I did this. I started my thesis 2 years. I've done it. I collected all the data. Everything was done, and there was still this argument that you are in preventive and social medicine. Alzheimer's disease, that is neurology. That's not something that you should be doing. So you need to change. You need to talk about diarrhea, malnutrition. Alzheimer's disease is not what you should be doing. And in the final year of my PG, I changed my thesis topic. So in fact, my final thesis for the MD changed in the final year, and my final thesis was the prevalence of neurological disorders in the community, and not really Alzheimer's disease per se, on the care arrangements of Alzheimer's disease. But I tried to make the argument that it is a big public health problem. It is a major public health problem. And now the WHO itself has declared that Alzheimer's disease and dementia is a major public health problem, and everyone needs to do something about that. But the reason I'm sharing this information is not to criticize the system, but to say that as public health experts, you need to feel the pulse of the community. You need to know what is happening around us, and things are changing rapidly. It probably wasn't a problem many years ago, but now it is. And with changing time, it's going to be a bigger problem. We need to be able to cater to those needs. It's not only dementia that's a problem. Older people have other issues as well. And so I'll be talking about this later after you do your group work. We had a program called DIL, which is depression in late life. And the whole focus was how to prevent depression in late life. And it's a lot of learning experience on how we developed the program to prevent depression in late life. This is published in JAMA recently. And I'll share the details with you and the findings of the study and how we did that, how we catered to the needs of the people, how we innovated to be able to bridge that gap that existed for dealing with the problem of depression. Again, it was a huge problem. Again, it was an unrecognized problem. People were having depression as a result of which they were not accessing healthcare and they were going into a cocoon. We had to go out of our way. How did we do that? Did we sit in our centers and do that, or did we go out of our way to their homes and try to do that? This is what the whole DIL project is all about. I was fortunate, and this is again when you're talking about leadership, I was fortunate throughout my, things knocked at my door, and I opened the door. I was the kind of person who, I was enthusiastic to do something, and I would just not leave it there. I would say, why did I do it? And so if I done, what next? That would be the question that I would always ask. And one thing always led to the other. In this picture, you can see two of my most favorite people who have mentored me. Professor Patel, who is a psychiatrist, is actually declared by Times as one of the 100 most influential people in the world. But he had a huge influence on me and my thinking, and people who tell you that innovation is cool. If you want to do something different, you need to do things that don't exist, that you need to innovate for that. Another person who I just happened to come across, and somebody who I have huge respect for, Professor Charles Reynolds. You can see him next to me in the picture. And he is the professor at Pittsburgh. He was director of the Aging Center there, and he was the, we worked together on the developing the DIL intervention. And a wonderful person again, and kind of learned not only from my patients, I learned from my mentors, I learned from my faculty at the medical college, Professor Motkare, who was my then HOD, who was very accepting of my different ways of dealing with things that don't exist. It's one thing, when you're working at the center, you could do things that are already there, and you run the programs that you're supposed to run. Two, when you sit at the center, you see apples falling from the tree, and you need to ask, why are they falling, and what can I do for this? And and that is what I would want all of you all to take back home. This is a workshop not to tell you how to take care of older people. This is a workshop on leadership. Is to tell you that if you want to improve the quality of life, how you should go out of your way and try to ensure that this happens. And what you need to also understand is this story about intrinsic capacity. That's something that WHO keeps saying. Now, we have this intrinsic capacity, but in the second half of life, it kind of falls. Initially, in the second half of life, it's high and stable, then it declines, and there's a significant decline. And this is our internal capacity to deal with things, our physical and mental capacity, our ability to walk, our ability to see, our ability to hear, our ability to think and remember. So our ability to be able to, do our day-to-day activities. So this is our intrinsic capacity. And we need to do something to improve the intrinsic capacity, keep people functional as long as possible. So when people say, I want to live long, but I don't want to grow old. What they actually mean is that I don't want to be on the bed. I don't want to be bedridden. I don't want to be dependent on others. I want to be as functional as much as possible. So one thing is about intrinsic capacity. Two is about the environment for the older person. So you need to focus on the environment for the older person, the furniture around, things like spectacles. If you go abroad, you will have somebody who is 95-year-old, who's frail, will take a wheelchair or a walker, will go to the supermarket, will enter the bus, and can manage. And the reason why that person can manage in that setting is because the environment is friendly for that person, because something has been done to improve the intrinsic capacity, because that person has got aids, assistive devices to be able to handle their day-to-day activity and not have a fall. Over here, it could be sometimes a difficult thing for a person to just cross the road because that sensitivity has not come in as yet. And so as leaders, we need to push for this if we really want to improve the functional ability. Functional ability is the combination of intrinsic capacity and the environment. So you have a good environment that is friendly for all the people, and you have tried to improve the intrinsic capacity. And we'll try to see how we can improve the intrinsic capacity in our group sessions when we discuss. The other thing that we need to keep in mind is the comorbidity. So you have cataract and visual problems, you have arthritis, cardiovascular disease and hypertension, neurological diseases like dementia, Parkinson's disease, stroke. We need to detect strokes early, TIAs, respiratory problems, GIT problems, psychiatric problems. So the number of problems that could occur as people grow old, and the combination of these problems actually lead to bigger issues. The combination of these problems plus the medications they are taking, plus the side effects of that, for example, postural hypertension could be there, or there could be gastritis. As a result of that, that will lead to some other cascading effect on something else. So we need to think of a person as a whole. If somebody comes to your clinic with a backache, don't just treat the backache and finish it off. Do a comprehensive geriatric assessment for that person and find out. It's an opportunity for you when an older person walks into your clinic to be able to find out, is that person at risk of having a problem? And you'll see a small video very soon, and you'll try to you get to understand better what exactly is the as a result of just taking things for granted and leaving it there, things can go wrong and can be quite incapacitating for an older person. The other thing we need to keep in mind when we talk about comorbidities is the presentation could be a little different. For example, if somebody with respiratory problems may not present with a cough, but could present with, as a result of the secretions collecting in, could present with some delirium maybe because the oxygen capacity has dropped, and as a result of that, and kind of these things we have understood when those of you who are dealing with COVID. So, and with the COVID situation as well, older people are at a huge risk because they have been indoors. And when we do the case discussion, we have one case discussion where we have to keep in mind the COVID situation as well. So how do we deal with all these problems is what we are going to discuss. So I've kind of highlighted 3 of my projects, which is the dementia one, the one on depression, and the other one we dealt with, because when I tried to go and meet the government, tried them that we need to do something for dementia, they would tell me, why only dementia? There are other problems. How do we deal with that? So we need to have an integrated program for other people. And COPE was kind of, this is a training program that we are having. We focus a lot on task shifting. So the existing people at the primary health center, can we train them to do something a little differently? And is it going to be effective or not? So this is a training program that we have here. We have Dr. Jyotiswaran. He was doing his PhD at that point of time and was, I was with him developing this the program, and now he's working with the WHO, and the WHO has come up with something called the ICOPE initiative, which we published recently in PLOS. ICOPE is integrated care for older people, and this is exactly what I would want you all to come up with. And this is something still in development and with inputs from you. So I want you really to do your group discussions well. We'll take inputs from you, and probably it will add on to this. This is the ICOPE group, the guideline development group meeting that we had in 2015. And that's somewhere you can see me again looking different from what I look now. But it was a fun meeting, and we looked at all the evidence that exists, and we tried to understand how we can best evidence-based solution. But I must say something about evidence, that we can only get the evidence for something that somebody has done research for. There's a lot of scope for research, and there is very little evidence that we get from developing countries and low and middle income countries. And so that is where your role can come in. You need to be able to come up and bridge the gap and come up with research that can actually contribute to our understanding of how we can improve geriatric care. So coming to this, the WHO has come up with the World Health Report, again on aging and health. And we had also earlier the theme of the World Health Day, which was active aging makes the difference. Healthy aging is really trying to improve the functional ability and trying to improve the well-being of the person. The government of India has taken major initiatives to be able to try to bridge this gap, and we have sent you in your folder these programs. I'm not getting the details of that because already running short of time, but we had the National Policy for Older People in 1999, again telling you about the rights of the people, what they need to have, the fact that they need to have social security benefits. There are various states that do very good pension schemes. For example, in Goa, you get 2,000 rupees. The different states have different kind of pension schemes, but they need to get food, they need to have access to healthcare. And then came the Maintenance of the Parents and Senior Citizens Act of 2007, which could be debatable, but the intention is good to ensure that older people are not neglected and the children take care of older people. And then came the National Program for Healthcare of the Elderly, which is under the Ministry of Health in 2010. Now, I'm skipping this because it has been sent to you before. But just to understand the kind of objective of the National Program for the Healthcare of Elderly, it provides for dedicated healthcare facility for older people at various levels of the state healthcare delivery system. So not only in tertiary healthcare, but also at the district level and also at primary healthcare. Human resource development. So if you want to cater to this huge population, you need to be able to get extra resources. The existing resources are quite exhausted, and every program gives them work as if that's the only program that exists. So whether it's leprosy or malaria or tuberculosis, there's a lot of work for the existing healthcare services. There's a lot of work for the ASHA workers. They're there for some other reason. But how can you still get task shifting done? And what they actually provide for geriatric healthcare outreach workers in these programs, strengthening the preventive and promotive and rehabilitative services. Very important, preventive services, and not only the kind of curative services, but also try to focus on rehabilitative services. Promotion of research in geriatric healthcare, which is one of the objectives of this program. At different levels, whether the regional medical institute, the training of postgraduate students, all these things are part of the program. What you do at the secondary healthcare level, what you have to do at the tertiary healthcare level, and at the primary health level. For example, or those of you working at the primary healthcare setting and some of you have mentioned that you already have a geriatric clinic, and you have a trained medical officer who's there at the geriatric clinic who has to do comprehensive geriatric care assessment. You need to ensure that you train all the manpower. You need to have a separate registration counter for older people and make sure that they don't wait for too long. Things like assistive devices can be provided through this. People can be advised on diet, on yoga, on lifestyle diseases, trying to ensure that comprehensive healthcare and trying to ensure the well-being of the person and help the person age gracefully. Arrangement for ambulance, etc. All these things are part of the program. And so we have a program and we have a community that needs help. And the program does provide, if you read the program, it's quite detailed and tells you exactly what you need. What is not there is getting the program implemented the way the program was designed to be implemented. So that is really not happening. It's happening in some places. We have some good models and we don't have some, in certain places there is a big gap as far as this is concerned. And the gap is actually the gap is about leadership. The gap is about someone who's committed, who would want to push for this and ensure that the program which is there in paper ends up in practice, ends up catering to the needs of the older people. So I'll stop here. And I'll go back to Archis, who will tell us what happens next. And we are going to think about how we can be a better leader in whatever capacity, wherever we are working, and what needs to be done. Archis.
Yeah, thank you.
Amit, yes. Can I add something to your presentation, Amit?
Sure.
Can I add something? Yeah.
Yes.
It was a wonderful presentation. I enjoyed it thoroughly. Just to add to it, like Census 2011, it says that as per 2011 census, our elderly population was 8.6%. And the projected figures are by 2050 is going to be 20% of elderly population. So personally, when I personally went through these figures, I felt happy about it, because when I'll be 70 years old, God willing, if I reach that age, so every fifth person is going to be of that age. So my community will increase by that time. So 20%, every fifth person is going to be elderly. And that is the very much reason we need to focus on this age group. Other thing that I would just like to add to your presentation, like you mentioned about National Program for Healthcare of Elderly, that was launched in 2010. I just want to bring out the fallacy or the shortcomings, the way we make programs. See, the first thing is we need to understand it was 2010 National Program for Healthcare Elderly was launched. In the same year, if you remember, another program was launched that was NPCDCS, National Program for Control of Non-Communicable Diseases, that caters to stroke, diabetes, hypertension, cancer. So it is overlapping, something which is overlapping and not has been mentioned in those program operational guidelines. Other thing is, in 2006, National Cancer Control Program was also launched. It was actually updated. It started way back in 94, 95, and it was updated in 2005, 2006. Now, if you look at the trajectory and the timeline of these programs, these three programs have so much in common. Because when we talk about NPHC, there is such a component of screening when we have to screen for cancers. Now, that has not been tied up with the cancer control program. Nowhere that integration is happening. And you are just producing programs over programs without thinking about what has happened to older programs. Now, the thing is, see, it is 2010 and this National Program for Healthcare of Elderly was launched. And today we are in 2020 at this point of time. And if we really look at the state of the affair, the program says, the operational guidelines says there has to be one geriatric clinic once a day at PSC level. There has to be daily geriatric clinic at district level. There has to be 10 bedded ward assigned for geriatric care at district level. But all of us know nothing has happened of that sort. Means we have not been able to execute it, right? On top of it, 2012 we launched NPCDCS program. For earlier few years, for 4 to 5 years, it went well. It was going very well. But now if you see in 2020, again, the drug stocks that were available at PSC, they are falling down. They're coming down because funding to that program also has coming down. So these are somewhere the program fallacies, the way we plan it, the way we execute it. So the operational research kind of thing, the how we are running those programs is greatly lacking. And the thing I would
The
like
issue
to add
again,
over
Ranjan,
here,
the issue, Ranjan, is actually leadership. So it has happened in other programs as well. So if you look, so if you look at the other programs like governance, so you look at the malaria program, the malaria filaria, etc. So now we have an integrated program as far as malaria is concerned. You have an integrated program as far as the RMNCH plus A is concerned. So again, this is something that we need to have an integrated. You just hit the nail on the head. And the issue is about leadership, issue is about looking at it. And we waste resources by actually having multiple programs.
Yes, we are wasting resources. Another thing, like recently this Ayushman Bharat has been launched. So I personally find it promising the way he's talking about health and wellness centers. And I personally visited few health and wellness centers that has been established at sub-center level, and they're doing well. From geriatrics point of view, what is being done in the Ayushman Bharat, they are running this health and wellness center, and NCD clinics are established at sub-center level. So for the first time in our, like the way we are running our program is for the first time, NCD clinics are being run at sub-center level. Earlier it were at PSC level. At PSC level, the NCD drugs were available, but now they are being made available at sub-center level. This is something promising. Other thing is weekly yoga sessions are being conducted at village level. Now this is something I find it very promising, because see, this physical activity culture, this whole culture is mostly focused on urban areas. A rural community where actually we need to focus more, where our more elderly people are staying, there we need to focus on health promotion and all these things. So these two things I find very promising in Ayushman Bharat, but hope so that they roll out well, or execution, the way they're going to be executed and continuing on. See, execution is again not problem. Like when NPCDCS was launched in 2012, earlier few years, it went very well. But then funding issue and continuing it on is a problem. Rather than continuing it on, we bring up some other program. Other government comes and they bring up some other program. So again, Archis, you can cover in your presentation, leadership and governance is a major issue. We are very good planners, but when it comes to execution of that plan, is really challenging for us.
Yeah, right. That shows the complexity of the issue. And
Yes.
of course, it will unravel more and more. I'm very sure that the audience has also had a taste of similar challenges. We
Yes,
have a
exactly.
very short video of Nora. We'll play it partially, and then we'll come back to Dr. Ranjan for her inputs on domestic violence for the elderly. We definitely have much discussion coming up on aspects of leadership, governance, and how we could manage a career here. So if I could be made the presenter, I'd like to share the screen and play the video. Dr. Badal, could you please make me the presenter?
So while this is happening, let me just introduce that small video. It's about an Irish community and what happens to an older person who has lost a husband, who says that she's having some memory problems. She's finding it difficult to cope. She has some health issues, and kind of one thing leads to another, and ultimately she ends up in the hospital and ends up in an old age home. So this is an Irish community, so the ending is in an old age home. In a community like ours, very often when the person is neglected, has healthcare problem, is totally neglected and abused, and doesn't have any healthcare at the place that they're living. So it is becoming a huge problem, especially, as I said, the people in rural areas where the children have migrated abroad. Are you trying to address that? Archis, you can start. Huh?
No, the share button is still inactive on my screen.
Okay, okay. Badal, is something happening?
Badal, can you please make me the presenter?
Badal, are you there? Ashwini?
Dr. Amit, do you have screen sharing rights?
I still have screen sharing rights, but yeah.
Okay, so shall I send the link for Nora's video?
I would have it, but it may not work. Okay, what we'll do, I think we'll go ahead with Ranjan's presentation.
Okay.
But I think Badal is not there. He won't make it.
I have sent you the link for Nora's video. Maybe that'll be very interesting if we could play. I think you can share your screen and still play the video.
You want me to do that? Okay, let me try that out.
Yeah. Just copy and paste it to your browser and it'll open. Okay, I am the host now. Why am I the host of this meeting? I can't present. The share button is inactive.
The host or presenter would like WebEx meeting to open on the website. Okay,
I'll try to get in touch with Badal. So just try to call.
yeah, please try to get in touch with Badal. I don't know what's happened there. He's probably gone out of for some reason.
I don't know why I have become the host. And how do I make Badal the host back again?
I have stopped sharing now unless somebody makes me share. I don't know. Can you all see my screen?
No.
No.
Because I have stopped sharing. So unless someone gives me the rights,
I can't
share.
Passing presenter rights to Dr. Ranjan. I passed it to Dr. Ranjan. Dr. Ranjan, I am sending you the link. If you could play it on your browser. You can share your screen and play it on your browser.
How to open it?
You just copy
Badal.
the Badal can. I think something has happened with the
I need Badal's help.
All you need is share.
Yes.
Copy the link from
But
the
I'm
chat.
not seeing that share option.
Sir, he'll be here. I have just communicated to the organizing team.
Yes.
Is any of you getting an active share button on your ribbon, like down below on the screen?
I don't have share.
Okay.
I'm
Dr.
not seeing
Ranjan, you're also not having that share thing?
No, nor do I have share.
No, I'm not able to see that share thing, no?
My share is bottom up, so I'm out of.
Hmm.
And I can't do that.
Can we call
Hello.
up Badal and Smith?
I now sorry, I've been disconnected due to network issue.
Oh,
I will
okay.
try to present again. Yeah.
Okay.
Yeah, so Achusman the rights.
Okay, sure.
Okay, now I'm getting an active share window. Right? Are you getting my screen?
Yes.
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 Perfect. Thank you, Badal. Thank you. Now this is Nora. We'll play this video.
In Ireland, as in many other countries, we are living longer and better lives. This means we have to make changes now to ensure we can provide well-planned, well-coordinated care for older people when and where they need it. This is Nora's story.
Hello, I'm Nora. Until recently, I was living on my own and was managing well, despite a few health problems. I've been living there my whole married life. I had friends in the neighbourhood, and my daughter lived near enough. I'm 85, and my husband died a few years ago. After that, I did start to have a bit of trouble managing around the house. If I'm honest, I felt I was getting a bit forgetful at times. About a year ago, I had a fall at home, and my daughter called the ambulance, and I had to go to hospital. I was checked over and returned home quickly enough, but while I was still getting over that, I became sick again with an infection. My daughter started to stay with me more as I wasn't sleeping well. She also helped to ensure I took the right tablets. I was supposed to get home help and see a specialist doctor for older people, a geriatrician doctor, I think. This was taking a long time, and while I was waiting, I had another fall at home. And this time, I broke a bone in my pelvis. When I got off the trolley and into a hospital bed, between the jigs and the reels, it took a long time to see all the people I needed to see. Therapists, social workers, and every ologist under the sun. To cut a long story short, I ended up in hospital for weeks. I tried my best. The nurses and staff took good care of me, but it was tough. It was noisy. It kept me awake at night. And I was in a busy ward with people of all ages and stages of life coming and going with all sorts of problems. I had to keep repeating my story to the nurses and the doctors. I was in pain, too sore to move round by myself. I got lonely and was upset at times. I hated that I couldn't do normal things or take care of myself. I just wanted to go home and get back to myself. But eventually, the doctor decided I needed a nursing home, and that's where I am now.
So while much of this may be relatable to urban India, of course, this is a video from Ireland. But,
Yes.
yeah, but things could be very contextual when it comes to India. Dr. Ranjan would like to talk of some other aspects related to elderly before we get on to.
Yes.
Yeah, I've made you a presenter. You can share your screen and take it forward.
Badal can do that?
You are already a presenter. Your share button.
Presenter?
Yeah.
Yes, I will try. Yeah.
I'm not seeing. I'm not seeing the share button.
Okay.
Hello, ma'am. Which presentation should I share first?
Domestic violence.
Okay, thank you.
So when it comes to domestic violence, we don't think like it's the elderly issue. Actually, when I was studying about geriatric health and when I came to know such a huge prevalence of geriatric abuse, it was very shocking for me. And so this presentation is about few issues, social issues, for example, domestic violence, ageism, and gender. So these three issues I'll try to cover in this presentation. So yes, so Badal, next slide. So let's try to understand how do we treat our elderly. So the very first slide talks about the living arrangements of elderly. So that tells us that 77% of our elderlies are staying with their families, 14% are staying with spouse only. There are 2% who are staying with relatives, and 7% relatives, they are elderly, they are staying all alone. Next slide. Badal, next slide. Yes. So can you imagine like 50% of elderlies have reported some kind of abuse. So this is a huge number. And when it comes to abuse, women, elderly women, they report higher prevalence of abuse than elderly men. Next slide.
Put it on.
Can you guess like from which state we have the maximum reports of elderly abuse? Can you guess which states have the highest incidences happening of elderly abuse? Yeah, you all are mute. So to my surprise, it was Tamil Nadu followed by Maharashtra. And if you look at their literacy rates, literacy rate of Tamil Nadu and literacy rate of Maharashtra is one of the highest literacy rate. So what does it tell us? Does it tell us the more we are literate, more we abuse our elderly, more we are educated, more we ill-treat our parents? And now this slide tells us who are abusing our elderlies. So 61% times it is daughter-in-law is a perpetrator of abuse, very closely followed by son, which is 59%, followed by daughter, 7%, and even son-in-law are abusing these elderly parents. 3% times these are relatives who are abusing elderlies. Next slide, Badal. So in most cases, these abusers are not reported. Almost 60% times these abuses are not reported. Only 41% times these abuses are reported. And when they're asked like why they're not reporting these abuses, there are various reasons. The very first reason being they don't want to bring that confidential family matter to the public. So they want to save their face. Other reason is they don't know how to deal with it. They don't know how to and where to approach and who will be helping them out. So there are a number of reasons they are not reporting these abuses. And this is where I think need to do something. There are certain intervention which are being done. For example, there is helpline number, but most elderly are not aware about this helpline number. There are certain NGOs like Helpage India, they are doing something for this domestic violence, but substantially we are actually not addressing this issue. The reason being they are not reported, and there could be other reasons. We are not prioritizing that problem as such. Next slide. Now, what are the reasons for this abuse? So the most prominent and emerging reason is emotional dependence on the abuser, followed by economic dependence on the abuser, changing ethos, and all various reasons. In Mumbai, the Mumbai police is doing a wonderful job. Like with every police station, they have registered the numbers and names of elderlies in their jurisdiction. And they're supposed to visit that elderly person every fortnight. So these are in pockets, something is being done, but it is not universally and not at national level. There is any effort to address this issue of elderly abuse. Next slide, Badal. Badal, next slide. Next slide. So there is this one study which tells the older persons who are ill-treated are more likely to die during a 3-year period compared with those who did not experience abuse. So this psychological abuse actually also reflecting on their physical health and expectancy of life is also being affected by this abuse. Next slide. Now we will discuss about ageism. So what is ageism? We have heard about sexism. So what is this ageism? Ageism is all about the way we stereotype, the kind of stigma the elderly face is known as ageism. We all have certain derogatory words we address elderly people by. We all are aware about those terms. We have heard those terms, and sometimes actually we may use those terms. So we all are aware. Just it has not come to us consciously that ageism is there in the system. But it's a time we need to be aware of such discrimination, this discriminatory thing the elderly people experience in their day-to-day life. Next slide. Now, it's very interesting. Women were viewed as elderly when aged in their 40s, but men were viewed more favorably as elderly only when they reach their 70s. So see, females as such, they experience double brand. They're already experiencing sexism, and when it get added with ageism, so females are even in more vulnerable position when it comes to aging. They experience the double brand of ageism and sexism. Now, one interesting study, like when do we believe that people are getting old? Now, this concept also is different for different countries. When I myself reading it, I find it very interesting. For example, in Norway, people feel that at age of 33.7 year, you are no more young. Like your youth is over by 33.7 years. And it doesn't hold true for all countries. All cultures have different ideas of getting old. For example, in Greece, they think that you are young till 51.7 years and after that you get old. Turkey is a bit kind. So they believe that 55.1 year, you get old at that time. So different countries, different cultures have different notions about aging. At what time actually you age, at what time actually you are called as old. So it's very different from all countries. I didn't get any study from India. These are all studies and findings from other different countries. Badal, next slide. Next slide. We will talk about this. This ageism is a lie in Aging with Grace, that how ageism is actually a lie. We will cover it in our next presentation. We will discuss it in detail. So age and gender also we need to understand. See, aging is a rural phenomena, as Dr. Amit mentioned in his presentation. Other thing that I would like to add, aging is a female phenomena, because as I have mentioned it over in this presentation, yeah, as you get 85 years of age, the ratio of women and men is 2:1. So as you age above 85 years, it's more a female phenomena. So aging, I would say, is a female phenomena and a rural phenomena. Now again, gender is very important when it comes to aging. See, the way our whole medical education and research has been developed, how it has been done earlier, whatever protocols of disease management, pathogenesis that have been developed for males, and they were extrapolated to women. Actually, women were not part of that studies, and women actually got affected by that kind of discrimination in research and medical education. To give one example, the way coronary heart disease develops in men and women, it is different. Pathogenesis is different, but we are not taught this in medical school. And what we are taught is the way coronary heart disease develops in men, how it presents in men. So what happens when that coronary heart disease develops in female in a different pattern? It is missed. It is missed. It is not diagnosed, and they present at a quite later stage. So females are affected by this kind of discrimination in research and medical education. But currently, the researchers all over the world, they are coming to this understanding, and now in all researches, it is mandatory to report their findings on gender-wise thing. They have to split the data, and they have to show actually how many female participants is part of that study. We all know the expectancy of life among women is more than in men. It is 4 to 5 years. Women on an average live more than men across all countries. Now this gap, how do we decide this gap? See, the countries with higher gender equity scores, like Scandinavian countries, this age gap is even wider. There, women live 7 to 8 years longer than men. The countries where this gender equity index is lower, like in India, India falls in last 1/4 quartile. Our gender equity index is very low. So in countries like India, women live only 3 to 4 years longer than men. So when we reduce the gender discrimination, women even tend to live longer than men. So there are different reasons why women live longer than men. I'll just mention few of the reasons. One reason that is studied and quoted is men engage more in risky behaviors like smoking, alcohol, and risk-taking behaviors, and because of that, their expectancy of life get curtailed. Another reason, very interesting, another reasons are genetic. Like women have 2 X chromosomes. Now X chromosome bear genes for immunity. Now women do have the benefit of having 2 X chromosome. So the genes having immunity that gives you a immune response is higher in women. So the immune system is supposed to be stronger and in women that gives them the advantage of extra years. Third reason, it says that the telomeres in women are longer than those in men. That gives them this extra life. There are again another many reasons why women live longer than men. But when we discuss about geriatric health, we need to understand women is a separate entity. They have their own issues. So in that geriatric health pocket, women deserve to have some place, and their issues need to be discussed separately. We need to have that focus. We need to have that gender lens while viewing things. I'll just share one thing. I was just going through the documents and policies regarding old age people. There are various schemes and programs like Rashtriya Vaya Vandana program, Indira Gandhi pension scheme. So I was just reading those documents, and I was very much surprised. The pictures they were using, they didn't have female representation. They all were males. You can go through those documents. Rarely females will be there even on the pictures. Now this is very contrary. This is very contrast thing, because aging is a female phenomena. We have more elderly women than men, and still they are not been represented on those documents, even pictures. You can just check it out for yourself. Females were conspicuously absent from the pictures that were used in those documents. Next slide. I think that's all. I think this is the last slide. Yeah, rural aging is a rural phenomena. Dr. Amit also has mentioned about it. So rural community has their own challenges, their own economic hardship, poorer quality of housing, less access to services. But there are few benefits also of staying in a rural community. They are more socially cohesive community, and neighborhood sense of safety and security is higher in rural community. So that aspect could be used when we plan programs for them. So that's it. So we try to understand about domestic violence. We try to understand ageism, gender issue in elderly, and aging in rural areas. So we try to understand these 4 issues in this presentation. Thank you so much.
Thank you, Dr. Ranjan. Now, before we get into the next session, let this be an interactive one. And I shall be talking to the audience for a couple of minutes, and I request everyone to chip in. Now, the thing is that the broader purview is that we have a major problem, a public problem that has not been adequately recognized, and the problem is going to increase with time, and something needs to change. Now, something needs to change, then someone has to bring in that change. If someone has to bring in that change and be the change agent, that person has to be a leader. Now, either you nominate yourself as a leader, or if you don't do that, the society will eventually identify a leader for itself and someone will lead. That person could take up the colors of being an activist or an advocate, or maybe for some individual interests. Now, the question here is, do you think you should be that change agent? And if you feel that you are the change agent, why do you think so? You may be having a deeper understanding of the topic, but that topic is still being unraveled. We do not have detailed evidence yet. The more you explore, the more you know. There could be more knowledgeable people around, people with their own lived experiences, very intelligent ones. They can fit into all formats. You want to take up that leadership probably. If you are taking up leadership, then you will need followers. What is a leader without a follower? So do you have followers, or do you have an intention of creating followers? Let's be that tangible here. And why should anyone follow you? Are you doing something exceptional? Are you doing something out of the way? Or do you intend to do something out of the way? Are you instilling hope that you will be able to bring in a change the way they want to see it? Are you bringing in more value to them? And if you're planning to bring in that value, why do you think that you will be able to do that? Do you have those resources with you? Now, to answer all these complex questions, basically, it all starts with a vision. So do you have the capacity to have a vision for yourself? Because at the end of the day, we also need to manage our careers. So do you see a viable career in this domain? Do you have a vision in which if you push the entire community, the community is going to benefit? So it's a value addition for the community. It's a value addition for the individual. And do you think that vision is futuristic enough? So it is not a set target, it's a dynamic target. And you are trying to move in that direction and trying to be very much abreast with the latest developments. Your background, your means it also includes me, because I think that this is a homogeneous crowd. All of us are MD community medicines. So it's a homogeneous crowd. So given our background, we have some understanding of public health programs, policies, maybe diseases, but we do not really understand multimorbidities in the elderly equally. So we do not have a detailed understanding, equal level of understanding when it comes to behavioral issues in the elderly, when it comes to other mental health issues, neurological issues, when it comes to their social issues, or even non-communicable diseases and also communicable diseases in the elderly. When we do not have that kind of an in-depth understanding of the things, then what we need is we need to compensate. We need to compensate probably through collaboration. So there has to be complementarity. And then once we collaborate, then it becomes collective leadership. So you can't always be a leader here. You have to be a follower at times. You have to be a collaborator, someone who's got the other person's back. It is an entire system. So you need to be a part of this system. So it is a system-wide leadership that you must inculcate, and you need those skills. So with this background, I have a couple of slides. I'll walk through those slides, but this is all contextual. I'll try and bring in some quotes from literature. This is all contextual. Please imagine within your own resources, if there is an organizational culture which is already sensitized to geriatric medicine or geriatric issues. If it is something very noble that you're trying to bring in, you are the first impetus for the department to think in that direction, or you are the sole warrior, a foot warrior who's going to start all the way from zero. Badal, if you could make me the presenter, I'll try and put my slides on.
Okay, sir, I will make.
So as I present my slides, I'll try to give a background to what where I'm coming from. So I had the opportunity to study leadership in health research in depth for about 3 years. So went around. It was a Wellcome Trust funded project where I got an opportunity of interviewing leaders at different career stage, scientists, basic sciences, socio-behavioral sciences, public health research, men, women across India. And I also had the opportunity of going and talk to 40 institutional heads. So the deans and the directors, met about 180 colleagues of the leaders, had their information and synthesized all that qualitatively. So this is one side. The other side was a Department of Biotechnology funded project, which also was, again, I had an opportunity of working on it for 3 years. It's still ongoing, where we had 7 apex institutions coming in. So there were basic science labs, radiology labs, community-based cohorts, clinics. And we were trying to develop registry and also trying to see incidence and prevalence of dementia, different forms of dementia, mild cognitive impairments, and all those associated comorbidities. So I had a chance of interacting with very ambitious researchers, hands-on, and also trying to study why some of them became leaders the way they became. Now, my presentation will be split into 2 parts. The initial part now will be of about 10-15 minutes, and I'll take on in details towards the end of the session. Now here, what we are talking is why leadership skills are important. No queries about it, like they are important and we all know. Over the last couple of presentations that we had from Dr. Amit and Dr. Ranjan, we very well realized that it is going to be a very complex situation trying to mitigate the issues of the elderly. And there are hospital-based services that we need to provide. And there are certain primary care, social services, or even mental health services, community-based services. And of course, there has to be an intermediate shared responsibility comes in there. So if we recollect Nora landing up in needing an ambulance or going to an emergency department or acute medical unit, has a short stay initially, later on fractured her pelvis and had a longer stay, needs intensive care or even internal medicine services or surgery or specialty services because she would be having comorbidities. All that needs to be handled within a very evolved medical setup. Now, here we are discounting other behavioral issues that Nora may have had, some mental health issues or anything. This is hardcore medical issue. In the community, once they are back at home, they would be lonely, or they may be getting, Nora got support from a daughter. Many times elderly do not get that support, and they need services which are based at home. So they could be mental health services. So there are some NGOs or trusts who are working over there, residential care or home care services, maybe setting up advanced clinical setups inside home, within home settings, or community beds, whatever it is. All of this needs a lot of coordinated community services and clinical coordination services. Here, if you look at it, I'm just trying to zero down to the purpose of why the values on which these services should be guided. Autonomy. So even if they are elderly, see, my experience shows that when I thought that these are retired people, I can just barge into their houses and fill out questionnaires, I found that they don't like that. They want that we pre-schedule appointments. So even if they are frail or they have some time, they want their respect, their honor to be maintained. And that's where empathy comes in. Autonomy is very important. And when it comes to their own health, we must empower those individuals, those families to self-monitor, to self-check, to be able functionally to have their own medicines in time to follow up on their health. Now, the next aspect is of engagement. Engagement means, are we able to strike a very interpersonal bond with the most vulnerable people? Because the most vulnerable elderly may not have a voice. They may not have a very conspicuous identity in the society. Their social participation would have been very feeble, and you need to establish that link. So those photographs that Dr. Amit was sharing when he was going house to house, that frail lady with the walker, obviously she's not going to come out and reach out to you to establish a relationship. So you need to visit as many times, and each time she'll forget. Each time her needs will change. So you need to have that empathy and that budding capacity where you are able to build relationships and sustain them. At the same time, are you able to individualize or personalize your approach? That kind of engagement will be valued by the individuals. The third part is of recovery. Recovery means again, you need to be able to individualize not just your approach, your friendliness, but your care, the care protocol that you're providing. That has to be evidence-based, that has to be within your legal boundaries, and at the same time, very much individualized. At the same time, there are many modifiable risk factors that you'll discover in their environment, and maybe if you are able to contribute there, you may be able to reduce their vulnerability to more difficult health issues. Resilience is yet another component where you need to bring in that awareness, that motivation, where they will be able to fight back whenever they're pushed to a corner in terms of health. Now, if we look at this kind of a complex arrangement, how do we resolve it as an individual? Now, imagine ourselves in our individual rooms, in our chambers, trying to think of the society, trying to bring in a change. This is this complex. We have a video. I'll play this video, and you will relate to some of these aspects.
Change it to full screen.
Unlike younger people, older people often experience more than one health condition at the same time, and these problems tend to be ongoing. Despite the presence of these conditions, older people can still experience a good quality of life and healthy aging. Most health services do not provide the integrated care that is required if older people are to experience the best possible health. Older people's health issues also are often managed in disconnected and fragmented ways and lack coordination across care providers, settings, and time. Integrated care is important to help older adults maximize their intrinsic capacity in the community. To do this, health professionals have to work as a team. In this model, health workers screen older people during routine home visits for declines in intrinsic capacity. Those with declines are referred for comprehensive health assessment. The focus should be not only on diseases, but on intrinsic capacity and how to maintain it. Intrinsic capacity is the ability to walk, see, hear, and remember, functions that enable people to do the things they value. The health team should design a care plan in partnership with the patient and caregivers, taking account of the older person's needs, preferences, and goals, and prioritizes interventions to support them together with the older person and caregiver. Many interventions can be done in the home, such as strength and resistance exercises, nutritional improvement, and home adaptations to avoid falls. It involves the whole community to promote exercise, address loneliness, and promote social participation. Integrated care can go a long way to improving an older person's intrinsic capacity.
Now, there are many avenues on, depending on our context, we can take a leadership. So all of this may not be equally weak in your individual settings. So there could be community health programs. You may be having a very strong network of community-based workers, or maybe certain social support groups over there. You can leverage that. Maybe you'll be able to identify certain community resources. Functionality, for example, in urban areas, these elderly people may not be able to order medicines at home or book a cab to go to the hospital. So there are cab services, there are home delivery services. So you need to connect. Those are certain value additions you can do to improve their overall participation or functionality. But when it comes to ambulatory care, will they be able to dial an ambulance when it is needed, or would an ambulance be available to them? Those are certain medical care changes that you can bring in. Acute care, of course, having emergency rooms which are more sensitive to the needs of the elderly, or even extended care, where you're trying to penetrate their homes and make it more viable for them, more sustainable, more affordable. All these components can be brought into practice using an integrated care model. Now, where usually we fail is we think entirely on medical care systems, whereas behavioral integration is also important. Behavioral healthcare systems integration is also important. And what we are seeing is absolutely manifest health conditions, but we are not very cognizant of mild cognitive impairment, mild behavioral impairment. So that's a big chunk which can be, progression of which can be slowed down, because once you land up with neurological conditions, once someone lands up with dementia or something, reversing that could be difficult. Maybe progression can be slowed down a bit. But this is a group which is again a much more proportion in the community, and you can intervene by increasing adherence to treatment or better control over non-communicable conditions which are actual major risk factors. For example, hypertension, diabetes, etc. If those control can be there, maybe we'll be able to avoid strokes, we'll be able to avoid kidney complications, etc., etc. Now, there are three elements to it. One is coordinated care, the other is co-located care, and the third is an integrated care. Now, coordinated care is mostly based on a referral system. So you have an outreach mechanism and you have identified specialty centers, both medical as well as behavioral intervention centers, and you have a robust referral mechanism, and probably that's what works in your context. So there you need to invest on your referral strengthening. If it is a co-located center, that means you have both behavioral as well as medical services under one roof. Maybe you can increase more communication or better response to cross referrals within that setup. So that's co-located. But what they really need is an integrated care. So you don't need a prescription coming from an endocrinologist, another one coming from a psychiatrist, another one coming from a nephrologist. Or is there a mechanism that you can roll it out into a single prescription? Because that's the elderly needs help, and they can't just go on clarifying on medicines. So can you provide them with one integrated prescription? Those are certain areas where we can easily intervene to show change. Now, when we look at the different integrated care models across different settings, we find that certain components are really constant in them. One, screening services that are in the community. So that could be population-based screening in terms of as is mandated by NPCDCS, or even screening for behavioral conditions, or whatever it is. There is always a gap with use of validated tools. So we do not have manpower who can use tools as accurately as they should be, and whether the tools are contextually sensitive or not, valid or not. So that's a gap that needs to be covered up to be able to scale out screening services to the community. Developing team-based approach. So it's not just a medical team, it has to be both a medical as well as a community management, a paramedical or a non-medical team, which is able to leverage community resources. Using a population management approach, that means you identify high-risk population and target your interventions towards them. So that could be within fragments within the elderly population who have risk factors and they need to be targeted. And your practice has to be evidence-based. So it just cannot be random practice. It has to be clinical practice guideline-based approach. You need to share information across different stakeholders, and all stakeholders need to take responsibility of the overall biochemical or whatever clinical performance of the individual. You cannot just blame shift. We cannot just say that, okay, this is medicine, this is nephro, this is endo or something. And telehealth, again, telehealth models are coming up worldwide, and expansion of telehealth services can improve access, especially to multi-speciality care. So these are certain very doable aspects where we can focus and take a leadership. Now, if we look at the more complex version, so maybe we are not a starter, we are already there, we have already done some work in geriatric medicine in our community. How do we expand our influence? Now, the influence can expand if we acquire a system-wide leadership approach. This is perhaps for someone who has already gone a bit into geriatric health, then can expand his or her area of influence to providers, to policymakers, to program managers, or to different non-governmental service providers, or even evaluators, so, or even private providers. So the ambit can be ever expansive as long as you increase more and more people under your zone of influence, and they align to your vision. You have that ability to negotiate, to motivate, then maybe you'll be able to show broader societal level change. Now that's when things become sustainable. Unless you bring in a system-wide approach, it will not be sustainable. Now here I'll stop with this presentation. I've split my presentation. We'll resume again later on. Over to Dr. Amit for the breakout session orientation. If there are any questions, maybe we can take up 1 or 2 discussion questions. Dr. Amit, you're muted.
Badal, I need to be able to share my screen. Oh, yes.
The thing is, we have a gamut of challenges. Maybe we identify the most resolvable challenge and start small. Bring in those changes, and then gradually one change will lead to another.
Oh, it's wrong. Where is that? Yeah. So welcome back, and I'll keep this short because I know we're running short of time. But I thought before we go to the group work, I'll just introduce what the topic is all about. We are not giving you a prescription on how you need to do it. I want you all to be as creative as possible. You need to understand that you are now in charge of a primary health setup, and you need to take the leadership role to make things work. And we've given you a case scenario. So the first one is taking leadership in as far as dementia care is concerned. And you may just say, okay, I'm not a neurologist, and so this doesn't concern me. But what I want to tell you is that the leadership that people have taken as far as dementia is concerned, I put some of the pictures here. For example, Dr. Jacob Roy, he's no more with us, but he was a pediatrician from Kerala, and his father had dementia, and he was running pillar to post in 1990s and trying to find some kind of help for his father, who was a pastor and was having memory problems, but there was no help. So he started what is called the Alzheimer's and Related Disorders Society of India, which today still runs in many of the states of India and provides services for people with dementia. Mrs. Jean D'Souza was from Goa, and she was one of the founder members of the Dementia Society of Goa. I told you when I was doing my study, we began to see a lot of people with dementia that exists, but we were not doing anything for people with dementia. So we just got together, and Mrs. D'Souza had her mother, who looked after her mother with dementia for 8 years. Kind of, she was driving force. She said, I have gone through this. I need to find solutions for other people. I want to share the information I have with other people. And that time, I tell you, there was no information available very easily. And currently now, Meera Patabi is in charge of RC, and that you can also see in the picture down. Dr. Radhamurthy, she runs something called the Nightingale Trust in this is one of the largest and one of the best homes for people with dementia, providing long-term care in Bangalore. And we have given a memorandum of understanding to the health minister. So a lot has happened. The point I'm making is that you don't have to be a geriatrician or a neurologist to be able to take up a cause. It is just something that is there, and very often it's common sense, but you need to know how to channelize this common sense and try to ensure that things work, because we have very good programs. As I said, you just need to get things working. So what is dementia and what is this term Alzheimer's disease? Alzheimer's disease is a form of dementia. Just as you have fever and you have malaria and tuberculosis and a flu that can cause fever, you have dementia, which could be caused due to various types of dementias. Like there is dementia with Lewy bodies, where somebody also has Parkinson's related dementia. But primarily, it's a condition where older people would forget to an extent that it affects their activities of daily living. You can see in Nora's video, Nora also said, I am forgetful. It could be a sign of dementia. If somebody who's old and is forgetting, you need to evaluate that person. So don't just leave that person saying, okay, this is normal forgetfulness, this is normal aging. That is what we always say. But it could be a sign of aging. It could be depressive pseudodementia. It could be that she's stressed, as a result of which she's forgetting, because that is also possible. Or it could be mild cognitive impairment. And I think Dr. Ashman has mentioned that mild cognitive impairment is one step before a full-fledged dementia. So again, this is an area that needs to be focused on, because if you address things over here, 30% of people with mild cognitive impairment may progress to have full-fledged dementia. Again, this is a condition that is happening inside the brain. This is not normal aging, which is something that has to be very clear to people. There are these tau tangles and beta amyloid again that has been kind of been responsible for what is happening in people with dementia. How do you recognize it? Memory loss. Memory loss, a lot of people forget, even we forget, but that is not dementia. Dementia is, we say dementia has occurred when the memory loss is to such an extent that it affects our activity of daily living. We cannot brush our teeth, we cannot drive, we cannot go and do all things that we're doing normally. A routine task becomes a problem. Difficulty in performing familiar tasks, things that we're always doing. If you cannot do that, it becomes a problem. That could be a sign of dementia. Problems with language. You tend to talk a language that you learned the first. You know, in Goa, for example, they would be very fluent with Portuguese, but you talk to them in English, they would have a problem, which otherwise they were talking in English, but now they can't really communicate in English. Disorientation in time and place. You know, all of us could get lost in the new place, but they could be totally lost in their own house. They may forget the way to the bathroom. So this is the kind of forgetfulness that is kind of that really emphasizes what dementia is. And I want you all to think on those lines. So if there is someone who is having these kind of problems, it does not get restricted only to memory. It also affects their behavior because they cannot remember, they cannot do things. Someone for thing they think it should have been breakfast, and they'll say, "You never gave me breakfast. I want breakfast again." Or they'll complain to someone else that so and so is not giving me breakfast, and there'll be fights in the house because they just don't understand what was happening. I tell you, when I was doing the study, 90% of the people and the families didn't know what the diagnosis of that particular individual. The person had dementia for many years, 2-3 years, yet they didn't know that this is a mental health problem. This is something that is affecting their brain, and this. Despite the fact that in the last 6 months or last 3 months, they had gone and seen a general practitioner. So the doctor who saw them gave them some vitamin tablets and sent them back. But it was a disease and it has to be tackled differently. And that's what you need to understand. So when you're talking about this group, in a group discussion, the other thing that I would want to highlight is that old age homes, there are many old age homes in Goa that don't really take in people with dementia. One thing they know is they would screen whether you have dementia or not. If you have dementia, they would not admit people with dementia in the homes. And these are the people who require long-term care facilities. That's the kind of journey of the old age homes. But we did do a study in old age homes. It found out that 9% of people in old age homes, once they admitted over there, somehow or the other, whatever problems they have, they do tackle them. We did a lot of training for people running old age homes and how to take care of people with dementia, and made a big difference to the quality of care they could provide after that. And understanding they had, they just could not. They then came up with incidents that they had. They didn't know how to deal with it then. But non-pharmacologically, we're not talking so much about drugs. Drugs are available for people with dementia, but we're not really focusing on the drugs, but we're focusing on non-pharmacological ways of dealing with that. So the other issue that you need to deal with when you talk about dementia is not only dementia, but also the caregivers. Caregivers here, as Dr. Ranjan said, is a gender issue again. So 80% of the caregivers are females. 50% are spouses who themselves are quite old and they find they're frail themselves, and so they have their own health issues. So you have to take care of that. They have their own health issues plus an older person in the house who's having dementia. Many of them are daughter-in-laws, and there have been conflicts in the past, but now how to deal with that. Very often there is this kind of a carer burnout. Some carers are caregivers, but also suicidal. So we have to address this issue, and how you can address the issue of caregivers. So when you're talking in your group number 1, the topic is leadership in dementia care. We will be sending this to you. It's a small community, and you are in charge of the primary health center, and you have to think of various things that you would do from a primary health center, starting right from scratch. Thinking of what happens to that person currently. So if a person with dementia had to come to your center now, what would happen? How would you be able to detect people with dementia? What you would put in place for that? How would you deal with the problem behaviors associated with dementia? How will you assist caregivers to look after people with dementia? How will you raise awareness? How will you, are there any successful models in your region for people with dementia? So think in terms of that. Think in terms of who at your center. So just think, do the micro planning. Who at your center will actually do the various activities that you say that needs to be done. So think about that during your group session. The second group session will be discussing about depression, and you need to understand that depression is, the problem with dementia and depression is that most often there is no local term for that. So if you say do you know somebody with depression, and then you will say, what are you talking about? But if you tell people, do you know I'm old and having memory problems, behaving this way, you'll be able to detect cases. So that's how I detected cases of people with dementia in the community, wherein we had case vignettes and we did snowballing as one of the things. So you go to the family and you find out there's someone with dementia, you explain to them this is what you're looking out for. They'll say, oh yes, I know so and so and so and so also has the problem. So you'll be able to find them out. So you need to think about on those lines. So sleep disturbances, CG caps is the mnemonic that we often use for this. In the last 2 weeks, do you have these problems? Sleep disturbances, decrease in interest, guilt feelings, energy has decreased, concentration problems, appetite could be lost, or appetite you maybe overeating, psychomotor agitation or retardation, and suicidal ideation. So these things are there. How will you be able to detect depression in that community? This is what the second group will be doing, leadership in care of older people with depression. You have a community where there are a lot of people who are having comorbidities, and also in a situation where COVID-19 pandemic, in order to maintain social distancing, they're sitting at home and not many people are meeting them. How in a situation like this you could address the problems of depression is what you need to ask yourself and discuss and present. So you have around 6 questions over there that you need to think about. So think in depth, think of how it will be implemented. So that is what you should do as a leadership. So it's not about what needs to be done, that we know, but how you're going to do it, which is more important. The third group is going to talk about the physical comorbidities and actually improving what we call intrinsic capacity. So how will you try to address these physical comorbidities and improve intrinsic capacity and come up with a model for integrated care of older people? So how will you do the comprehensive geriatric assessment? How will you assess whether there is visual problem, hearing problem, locomotor problem, cognitive decline, psychomotor problems, or problems associated with conditions such as urinary incontinence? Again, a big issue in older people. It is called one of the most silent complaints of older people. They don't talk about incontinence. They feel that, okay, they're not functioning well. They cough, the urine may dribble. So, and they don't talk about it but it has a huge impact on them. It has a huge impact on their mental health, and they withdraw from society, as a result of which other things happen. So keep in mind how you can deal with that. If you want to get a person to be functional, to remain active, you need to address these problems. You need to make sure that they're physically strong, the mental well-being is ensured. You need to ensure that they don't decline cognitively. So you need to enhance their cognition. How can you do that? How can you ensure integrated care of older people is what third group is going to discuss. So we'll break up for the groups, and Badal is going to divide you into groups. I know it's a very small group, and breaking up is going to have a very small sample size, but it's a quality group. So I'm sure you'll come up with great suggestions. So each of the groups will be guided by one of us, and I will be dealing with the group on dementia. Dr. Ranjan will be there with the group on depression, and I will be Dr. Ashman.
I think we should allow them 10 minutes.
Someone asked me. For the discussion? Yeah.
10 minutes for a breakout?
Or there will be a presentation at the end of it. So one of you will have to be a leader and be able to present what the group felt.
Can be a non-PPT also. It has to be a summary. 2-3 minutes or 5 minutes.
Non-PPT also, yes. Yeah.
So we're breaking out for 10 minutes.
So we are running short of time. So it's 4 o'clock, and we will convene again at 4:15 then.
4:10 shall we make it instead of 4:15?
Okay, 4:10. Done. 4:10. So start discussing immediately and ask your if you have any queries.
No, but who is deciding that who will go into which breakout?
Dr. Badal will do it.
Yes, sir, I'm doing it.
Excellent.
हेलो अरे किसी को वहाँ ऑफिस भेज दो ना वो उनका कमेटी रूम बनेगा
वहां पर अपने पॉइंट बता के आते जाते कर बताते पैनल डिस्कशन होगा
ये बोलता सेकंड ब्रेकआउट सेशन 3 बराबर है ना?
हाँ
ठीक है, ये इनको ऐड करना है।
Badal, what's the problem? Some issues?
In the meanwhile, if you could decide that who will work into which
Sir,
group,
breakout sessions are ready, sir. Shall I start?
Yes, please.
Yes.
Yes.
Okay.
Please.
Okay, sir.
Yes. Are we all meet? Great. Badal, can you give me sharing rights? Yeah, great. I've got that sharing right. And I need to know how to get there. So are we ready? Has everyone joined?
Yes, group 2 has joined back.
Okay, now both of you are here. Is everyone? So, the groups will make the presentation. So should we go ahead with group 1?
Sir, everybody has returned back.
Okay, great. So I think group 1 can start their presentation. Pratiksha was the group leader in group 1, and we are talking about dementia. So Pratiksha, could you highlight what the group felt about dementia and how you as a leader would be able to deal with the problem in the community where a lot of people with dementia exist?
Very good afternoon to all. And the topic for a discussion was the leadership in dementia care. Sir, am I audible?
Yes, yes, you are.
Yeah. So at the primary health center, the first question was, how would you detect the people with dementia? So first, as discussed by Dr. Amit, it is essential for the medical officer or whoever is taking care at the PHC to assess the patient completely and not just catering to their individual complaints for which they are coming to our center, as they might not be knowing that it is related to their dementia problem also. So assessment of the patient completely is very important for that. And that is also related to their various behavioral problems which are related to the dementia.
I think what you highlighted is that there was a need for raising awareness
Yes,
about the condition, how,
raising
and you are
awareness.
discuss
Yes,
how you
yes.
do that. Yes.
Yes, by we have to educate the community by making the dementia-friendly communities, having the proper outreach program sessions for the dementia diagnosis and treatment, also to diminish this big barrier, to have the proper follow-ups, having including the Anganwadi workers and ASHA workers to reach out to the people who cannot come to the primary health centers, and or geriatric, or by making the geriatric health workers to reach out to such kind of people, by taking in the help of the media and different spokespersons or different chariot members or community folk persons to reach out to such kind of peoples for further assessment. And for the different kind of models which we can use to address the need of the people with dementia, as told by Dr. Amit, we can enhance the approach of telemedicine to help the geriatric people for this thing.
The other thing that you all had mentioned is the how you're going to make the referral convenient for the people, and how would you ensure that there is post diagnostic care and support that you could give from your health center. So you need to build capacity and train your staff to do it. It is not possible as of now. Even if a person comes with dementia to you, I'm sure if you honestly want to say that you will not be able to make the diagnosis. And I couldn't do it when I was in your state. I built that capacity, and we built the capacity of other people to be able to reach out. And now even, and you'll know from my program that I train lay people. It's not that you need to be some extraordinary qualified person to be able to address the issues in families of people with dementia. A lay person, somebody like an ASHA worker, could also be trained to do that. Now, will an ASHA worker do it, or do you need somebody else? And I think you need somebody else, genetic linked worker who needs to be trained specially for this job, rather than give the multitasking staff to do it and extend this. It will not work too much. It will not work too well. Okay. Is that all? Anything else, Pratiksha?
Yes.
Excellent. Very good presentation.
No, sir, that
The
will
next
be
group.
all from my side.
Yeah.
Thank you, sir.
Anyone wants to add in anything else about dementia care and taking the leadership in dementia care? Dr. Ranjan, Dr. Ashish wants to say anything.
Yeah, did we also talk about caregiver burden?
Yes, they had spoken about it very less time. The rush through it, but actually we did talk about what is it how will you address caregiver burden?
So by talking to the primary person.
Yes.
Yes, sir.
First, you need to identify the burden. If you don't identify the burden and the stress in the caregiver, you're going to miss it out altogether. They will not complain to you. They will complain about the person. They will not talk about themselves. And generally, when they come with a patient, you will decide, okay, that patient has come to me. I will only treat that patient. You don't think that you need to also address the issues of the person who's come around and person who's looking after. That person doesn't get assessment. But in geriatric care, you need to ensure that you train the caregiver as well and you address the issues of the caregiver as well.
Yes, sir.
Yep. Would you like to present?
Yeah. So I'm presenting on behalf of let me just put my video on as well. This is we had depression, the case of geriatric depression. Under that, very quickly, one of the first question was that how will we detect the older people with depression? So one is the psychosomatic complaints, and also the other could be that if there is a trigger in the family of any catastrophic loss of the close family member or any other issue, that could also be taken care of. But then if such a patient is brought to a clinic, then there are geriatric depression scales. One has 8 questions, and another is 20 questions. Probably the 8 questions will be easier one to identify and screen the patient. Then the intergenerational concept, as Dr. Ranjan had suggested the name, but the point that I was making in the discussion was that it is the grandchildren who could do the bonding with the grandparents. So that will help the bonding, as well as probably try to cajole them, probably try to let them take their stress out, trying to understand their pain point. What is it that is causing them depression? That could be there, and this is also the way that we can address the depression. In terms of helping such a patient or a group of people in a geography, it's the self-help group that could be tried. We learned the experience of Dr. Ranjan into this, which is a good point. In fact, I was sharing my point that my parents stay in Chandigarh, and they have a small spiritual group, and every third day or fourth day, like Sundarkand and many other the kind of scriptures they read as a team, and of course they take care of each other. So those kind of self-help groups are important to prevent depression in the first place. Because if there are 5 or 6 or 7 such peers in the nearby families, if one of them happens to be tending into depression, the others will try to pull them out by counseling them, by citing scripture, by citing certain other incidences, etc. Fourth is how will they do daily activities? It is again the intergenerational build-up, the support from the family, within the family, and also from the peers can help them ensure that they carry on with their daily activities. The initiatives to help them can be planned, taking care of the physical, social, mental, and spiritual well-being. Open gyms in certain municipal corporations, like in again in Chandigarh, I know that example is very good. That early morning they go for a walk, but then they also do certain exercises to ensure that they are physically fit, socially well knit. I still remember the older scenarios wherein anyone can walk into the other's house without even knocking. Now, probably in my parents' place it is still the same, but in bigger like in condoms that were in the condominiums that we are living in gated community in places like Gurgaon, where I'm currently placed, this is not happening. But then that is a real bonding place. That if you walk into anyone, even if he or she is eating or sleeping, then of course within the privacy boundaries, that is also a very good bonding. coming to the fifth point, how will you improve overall health, their well-being? I think it's a team game. It's not a one person's job, and the major role has to be taken by the family only. If there are other family members, probably they will have to come up. They'll have to ensure that the so-called depressed person's mood is always on the positive side. They keep him engaged into meaningful discussions of his interest. Uh, I was thinking of successful models. While I'm not personally experienced any successful model, but there could be talks, certain subject matters coming and talking to them. Say a cookery expert, say some politicians, some small time political expert talking to them about politics, which is of their interest, and then passion trips. They could be taken into a passion trip of their interest, say bird watching, say whatever they are interested in, and of course, I'm in a strong favor that in the elderly age group, for sure, the spiritual groups have to be there. The scriptures are the great support for the elderly. They need to utilize their time in that. Then probably they will have a very clear thinking. Whatever they're lost or whatever is the reason of depression, let it go, because ultimately they have to focus on their next life. Thank you. Back to you.
Yeah, I think excellent suggestions, and thanks, Dr. Ranjan, for leading this. What you highlighted was the spirituality. There are a lot of problems that we are facing in our country, but there are also strengths in our country, and we need to identify what these strengths are and build on them. And I think this, what you also mentioned about this social isolation, which is causing a big problem. With COVID-19, this kind of even highlighted. There should be kind of physical isolation, but there shouldn't be social isolation. The people could contact each other, maybe on phone or some way or the other, to reach out to older people. I know of older people right from the time the pandemic was announced, they're still inside the house. They have just they're so scared now. Only for the vaccine they have come out and gone back inside. So it has caused a huge impact on them, and one needs to address this need. So good presentation, Dr. Om. Should we go to the next? Archis, anything you want to say?
No, I was just trying to imagine where exactly would they get support, because depression and dementia, if they coexist, how are they going to handle? Is it a neurological?
Very often they do coexist. So the way we deal with it is one, there are multiple players over here, and you have to get the whole community active. And I think, as Dr. Pratyaksha mentioned, this term dementia-friendly community. So it has to be an elder-friendly community. So it's one person can't do the job. At the health center, there's a limited work they would do. Health center should have outreach work. So the community health workers, the geriatric health workers should do the outreach, but they should be able to motivate other family members. And the way we do it is we do what is called family counseling. I'll be talking about that, and trying to get the other family members to chip in. So sometimes the whole burden is on one caregiver taking care of an older person with a problem. We try to get the other family members also to chip in. So they can, even if they don't do direct caregiving, they can do the shopping, they can do the paying of electricity bill, and all the other issues can be dealt with them. So this person has some kind of a break time or me time for themselves to be able to deal with the issue. Panchayat members, and then the social welfare. At least in Goa, we have a system where you have a project called Umid, wherein you can hire a place. The government gives funds for that. They can get together for playing carom, etc. Small games, reading newspapers, just meeting other people, because this social interaction is important. For one, preventing depression; two, to prevent dementia as well. And earlier the intervention, the better it is. And that is what the third group would be talking about, the early interventions to improve cognition and improve psychosocial health. Yeah. Should we go to the next group?
Yeah. Thank you. Yeah. Group 3. So group 3, could you please present?
Shall I go ahead, sir?
Yep.
Yes.
Okay. From group 3, so the topic was leadership in enhancing functional capacity of older adults and providing integrated care. So as per the discussion, it was decided that this should be a multi-stagic approach, with the core being from the primary health center or the rural health center or any health center of that particular area. So at the first stage, the people living in that area will be on an individual basis, house to house visit will be done, and their problems will be assessed. So all the elderly will be, it's a screening process which will be done. So the main things that will be screened will be there, whether what is their daily activities, how much they're able to do, what is their social status, what is their financial status, what is their emotional status, mainly through depression, anxiety, and stress scales that will be used. And so based on all this, plus their comorbidities, what are their comorbidities and what medicines they are currently on. So based on the needs that arise of that particular area, at the second stage, there will be a comprehensive healthcare being provided to them, probably as a village camp being conducted, where the people identified who require some treatment or who require further evaluation into their problems, they can be brought with the help of local volunteers from the area in case they need help, or if they can come on their own, that will be great. So they will be mobilized to come to the camp in that particular area to get a complete evaluation in one place on a particular day. And then further, they will be, in case they need any treatment or further care, that will also be done. At the same level, they will be, at the same stage, they will be taught some exercises. For example, many of them have physiotherapy, joint problems, and so on. So some amount of basic physiotherapy also will be taught to them, which they can continue at the household level. If they require supervised physiotherapy care, then the caregivers in the family or even the volunteer caregivers for those who are living alone can be taught how to take care of these persons. So then at the family level, all this is at the individual after screening. At the family level, again, after the needs assessment and after the camp is conducted, the family will be counseled on how to maintain the elderly for their activities of daily living. In case there are small modifications which are required to be done at the household level, for example, putting bars in the bathroom so that they can hold on to and they can get up, or any other minor things in case they need a walking stick or a walker, something to mobilize them and help them in taking care of their daily activities. Also giving them based on, they can themselves be asked what they look forward to in a day. So finding their interest and helping them do some particular activity every day to feel useful to the people around them. That is one of the other things we thought of. It can be as simple as watering the plants or probably chopping vegetables, whatever is their ability. If they are able to do a particular activity, they should be able to contribute to that for the people around them. Plus at the community level, choosing volunteers from the community. It can be in the form of NGOs or it can be volunteers from the particular area who know the people. They can be helping in supervising the medication in case they require any hospital, whatever hospital care or any other care, whatever they require. Even for the daily activities, if they require any help, the volunteers can help them out in that. And even it can be at the household level also. If the family is not able to do it, then you have an external volunteer doing it for them. They can also help in keeping in touch with them. And also at the community level, as was pointed out in group 2, there should be some amount of social interaction between the people. So all the elderly, usually they get together and they chat about their problems or they chat about their daily happenings. So that should be encouraged. Plus even spiritual groups or teams should be there. In this COVID situation where people are, especially in urban areas, they are still isolated. So in that, I think that through video conferencing and video calls, they should be monitored. Just on a social basis, but it's an indirect monitoring that is happening to see whether they are depressed or whether they require any other medical aids. So this can be done at the community level. Then this has to be maintained through the volunteers. This will be an ongoing process with the rural health center head or the health center head being the main monitor for the whole activity. So this will be a continuous process which is happening. And as and when required, maybe new modifications can be done. But the main core should be to help them in carrying out their day-to-day activities. And in case they need any counseling or mental health expertise, or even somebody to talk to, those aspects should also be taken care of. Thank
Yeah,
you.
excellent, excellent, Ashwarya. And I like the idea that you spoke about the, if people don't really come to you, can go out, you can have camp systems. And, in Goa also, we had a number of these camp activities for detecting, say, eye problems, to detect NCDs. And they were mega camps. At every camp you'll have some 2,000 people coming for that, and they have worked successfully. I mean, if I had to think of it earlier, 2,000 people at a camp, how are they going to manage and all that kind of stuff? But it was the vision of a dynamic health minister, I must say. He comes up with the program, and this is out of the box. It's not happened before, and he does it very well. And it's because multiple. And the other thing you highlighted is the coordination of the panchayat. And there are people who are doing this kind of work. Get all the resources, put them all together, pull them together, and do one activity, which is what they are doing. So it will be successful. The other thing you mentioned is medication. You always have to assess the medication. The older person is collecting the medications over the last 10, 15 years or 20 years, maybe. You go to multiple doctors, sometimes they take the same medication with a different brand name from 2-3 different people. And they're taking some other medication. They were supposed to take it for 5 days. They continue with it. They're taking some sleep medication over the counter. So all these things lead to a problem. You can have people presenting to you with frank dementia, but actually is having a drug that was causing the dementia. So you need to sometimes understand what exactly is happening. The falls could be due to medication. So you definitely need to check what medications they are taking and address that. In the interest of time, I'm going to do this thing quite fast. Thanks, Pratyaksha, and thanks, Dr. Om, as well, for the wonderful presentations. Anything else Dr. Ashish or Dr. Ranjan wants to add?
Nothing at this.
In the interest of time, I'm just trying to go ahead. Very quickly, I'll tell you what we did for dementia. I'm not going through the whole story of how we got there, but we did a lot of research to find out what is really required. And very basically, they required to raise awareness about dementia, because there is a lot of stigma. And if you're not going to raise awareness, people are not going to come to your health center, and they will still say it's normal aging. Care had to be home-based. As you can see, some of our counselors going and visiting people's homes, because a person like that cannot be carried. They're quite poor. They don't have a car. They can put a person with dementia and get to your health center. And so they just can't afford it. But who's going to go to their homes? So it has to be home-based. It has to be affordable. If you're going to have people going to the home, it's going to be very expensive care if your doctor goes there. Can you send the alternate, can you shift the task onto some health workers who would be able to go and visit? But if the health worker goes, the health worker may not know what to do. So the health worker has to be trained how to give this kind of care. The care has to be person-centered and not disease-centered. So it has to be integrated. And you also need to definitely address the issue of the family caregivers. And this is what exactly we did in our initial project. This is somewhere in 2000, 2002 that we started off. This is a project that we did with the help of the Ministry of Social Justice and Empowerment. And that is me again, many years ago, with Dr. Vikram and a whole team of psychiatrists and social workers and lay health workers. Actually, we trained people who are just interested in doing community work. And we trained them to go and do this kind of intervention. And it worked out extremely well. We did a randomized control study on this, and we tried to find out what was the impact of doing this. So what exactly we did when we went to the houses, we went and addressed the issue of the caregiver first. So we kind of understood that if we don't address the issue of the caregiver, we will not be able to address the issue of the person with dementia. So it's through the caregiver that who's going to change the quality of life of the person with dementia. But the caregiver herself is sick and stressed and burnt out and thinks that is suicidal. No matter what you train them, they will not be able to do the job. So you need to address the issue of the caregiver. And believe me, it was a very important kind of component of the whole intervention. They said that 10 years I'm looking after so and so. Nobody even asked me how I feel in the house. Let's take it for granted that that person is going to do the job. As I said before, it is a female issue. It is like 80% were females, of which even 50% were spouses who themselves were quite old. The other issue that we had to address is try to help the caregiver keep the person with dementia functional. So address the issues of activities of daily living, how to help them do the activities of daily living, how to deal with the behavioral problems. The third issue was the R, okay, if you have a mnemonic, your care. So care is for the caregiver and for chronic ailments that we addressed in people with dementia. A is for the activities of daily living, and the B is for the behavioral problems associated with it. R is for reminiscence therapy. So we try and reality orientation. So we try to help the person cognitively. So some kind of cognitive exercises. We take old photographs, help them understand who is who in the old photograph. Happy moments. Just put 20 photographs together. Put a big calendar with so they kind of tell them what is the date and orient them to where they are. E is education and the kind of emotional support that we gave them. So this is what care intervention we did. We try to address these activities of daily living, how to help the person with dementia eat well, how to help them dress, how to help them go for the toilet habits. So there are certain things that you can do which are non-logical, and we can send you all the details on how this is. At the same time, we also try to help them deal with the behavioral problems like hallucination, repetitive behavior, wandering, suspicion, screaming episodes, depression. So these again, we try to educate them about how to do that, to do that, and we try to avoid medication as much as possible. In fact, we would review their medication and reduce it rather. So, for example, if somebody had an eating problem, we would try to address it by having a understanding what the routine is, understand what exactly is the eating problem. It could be the time of eating for the person with dementia. So they change that timing, ensure that they get the food on time, encourage self-feeding, serve familiar food that they are comfortable with and they like, encourage a lot of fluids, etc. So simple things can change that. Ensure sleep. If they sleep well, their behavior improves quite a bit. So different measures that could be taken to ensure that they sleep well. If there is wandering, they can see a person with dementia and our home care advisors trying to help that person deal with it. Sometimes it's very simple, as in just put a lock on the gate. But if they see a lock on the gate, they may try to open it all the time. So you need to put a lock on the gate and cover the a very simple measure to be able to deal. Sometimes it's just common sense, but nobody was using the common sense for the last 5 years. When we try to assess what the problem is, we can come up with creative solutions to deal with the issues. So these are various pictures of a home care advisor. It was a study that we did through a randomized controlled study, and we measured the stress in the caregiver by measuring by using the GHQ scale, by doing the neuropsychiatric inventory questionnaire, and measured the Zarit burden. So in a 6 months time of sending counselors to their homes to deal with this for the people with dementia, we found that the GHQ had decreased. So the stress in the caregiver had decreased. The neuropsychiatric inventory question had decreased. So the behavioral problems that people with dementia had decreased, and their perceived burden had decreased significantly. Now, this is also part of what the researchers come up with called the MH Gap program, the Mental Health Gap program, and you can always read that I would advise you to read that. Just like you have an IMNCI program, the MH Gap has algorithms wherein they tell you how to deal with various problems like dementia, depression, psychosis, epilepsy, etc. They very clearly mention that in case there are no specialists, then the non-specialists can be trained to be able to bridge the gap as far as these conditions are concerned. An important message I would give, I'm part of a group called the 1066 Dementia Group. That is just a group of experts thinking on similar lines, people from Niemans and other places dealing with people with dementia. And the whole philosophy is that good quality research will help generate awareness, will help develop services, and will help shape the policy. So this is the whole aim of our research. We just want to research for something. We say that what has this come up with? What to do next is what, and the 1066 is named the fact that only 10% of interest goes to, as far as research is concerned, go to areas where 66% of people with dementia live. So in the developing countries, in the low and middle income countries like India, China, you have 66% of people with dementia of the whole world, but only 10% of work and services happen in these areas. So we need to readdress that kind of a discrepancy or the gap in services. And we came up with various publications. This is our publication PLOS, and then there is the subsequent publication packages of care for people with dementia. Several books were written by us, or chapters written by us. This is where RC has grown over in various states in India. It started off in Kerala, in many parts of Kerala, but then it went on to other parts of India as well. The medical students or the medical colleges, wherever you have an opportunity, you need to educate people and get people sensitized to this. So participate in various events and try to educate people. You can see these photographs. We had a kind of a street play. We had a small skit on trying to educate people on dementia care. We had education at the OPDs, where people will speak about what recognizing dementia and the signs of dementia are very important. Then we tried to have a lot of the home nursing school. So a lot of families were saying they wanted home nurses to look after people with dementia, and nurses would be very expensive. So we trained some students who were like school dropouts, 8th standard, train them in kind of home nursing. It was a 1-year program. We developed a curriculum for them. And fortunately, the Ministry of Social Justice, the Social Welfare, recognize this course and gives them a certificate now. So at the end of the course, they get a certificate from the social welfare, and they can be employed in various people's houses to look after older people with dementia, but other older people as well. We raised awareness and we did everything under the sun that we could do. Creative ways of trying to do it. We walked at the carnival, we danced somewhere, we were on the street wearing some strange clothes like that you can see in the pictures, just to attract attention. We had these poster competitions, we had websites, we had people visiting us on interviews on television to raise awareness about dementia. When we started off, no one knew what it was. But now, when there's Alzheimer's Day, for example, the newspapers will actually contact us and say, okay, please write an article. There's Alzheimer's Day coming. We don't want to feel out and not have an article on dementia. So, which is a good thing. There is awareness. The people want to know more about Alzheimer's disease and dementia, and we kind of have reached that level where we've raised awareness, but we need to still develop services further. Movies are very good ways of trying to raise awareness. This is the movie Astu by Dr. Mohan Agashe, and many of you know him. Excellent depiction of a person with dementia, very sensitively done. It's a Marathi movie, and if you have not seen it, please do go and see. It's about a person with dementia who gets lost and taken care of by a family who don't really understand dementia, but understands the concept of love. And what it says is that to look after a person with dementia, you just need to have that kind of empathy and that connect. It is not that you need to have a lot of knowledge and education to look after a person with dementia. It makes sense. But we need to act as catalysts to be able to deal with that. There are a couple of other movies. In the movie Black, towards the end, Amitabh Bachchan has dementia. At the end of the movie, this is Dr. Mohan Agashe, actually. We had a kind of a panel discussion on the movie, and we spoke about various scenes that were done and how it could reflect on how we can relate to that and how we deal with people with dementia. Recently, I was part of the Lancet Commission on Prevention of Dementia, and we came up with, we looked at the evidence, and in fact, dementia can be prevented. And we need to focus on prevention of dementia as well, especially for us from the Department of Preventive Medicine. Focusing on prevention of dementia is important. We came up with 12 of the factors that were found to be useful, like education, early education, especially below the age of 20, physical activity, social contact, trying to deal with hearing loss. If people have hearing problems, they're more likely to develop dementia. It's a very strong association there. Hypertension, obesity, smoking is related to dementia. Depression is, either could be causing dementia, or it could be the cause of dementia as well. Because you have dementia, you could end up with depression. So there could be some reverse causation there. Diabetes is important. Alcohol intake is related to dementia. Head injury, and even air pollution. Air pollution is now known to be related to all kinds of cardiovascular disease, strokes, etc., but also related to, very strongly associated with dementia as well. What we found out is that if you address these causes, we can reduce the incidence of dementia by almost 40%, either reduce or postpone. So if a person who was supposed to get dementia at the age of 65 now gets it at the age of 80, it makes a huge difference for their quality of life. So that is the whole concept about the integrated care and trying to improve intrinsic capacity so that diseases can be prevented or at least postponed diseases. Now, keeping this in mind, in Goa, we had these kind of outreach programs in schools, because we want to change behavior, it has to happen in schools. So educating school children works two ways, and we call it the Minded program. It works two ways. Is one, we try to educate school children to adopt a brain-healthy lifestyle, to make them sensitive to grandparents in the house who have dementia. So they can, through them, we educate the family. So, and it's worked very, very well. In fact, I used to do it for 8th standard, 9th standard students, but I also did it when my son was in 4th standard, because the teacher asked me to do that. And even that class, it worked out very, 3rd and 4th standard students also, it worked out very well. They understood dementia very slowly, how you can adopt these brain healthy activities. and how you can detect dementia. We show a small movie, etc., and it works out well. So you need to be creative in reaching out to them. These are again some of our minded programs that we did, and we coordinate with various kinds of NGOs. I don't have to do much; they do everything. I just have to go and talk about dementia. But we now have capacity to be able to train other people to be able to do these kind of outreach programs. A lot of focus on physical activity, because one of the factors that can prevent dementia. And so we had these memory run. Usually most of the activities are surrounding the Alzheimer's month, which is the month of September. 21st September is Alzheimer's Day. And also our volunteers now have started what is called a memory cafe. And the whole idea is you have, as you can see in this picture, elders get together on a weekly basis. There is one group that meets on Wednesdays and one group that meets on Mondays. And they have various kind of brain activities. They solve puzzles. They do some Zumba class and something or the other. Now, because of the COVID, we are doing the whole thing on Zoom. Zoom has really changed their life also. It's make things easier. In fact, you don't have to. They miss meeting each other physically, but then the training still goes on. And they're very enthusiastic people who we give them exercises and they'll come up with try to do something that stimulates the brain. And the whole idea is to keep them healthy and improve cognition. We have written the dementia in the report, which is submitted to the government of India with recommendations on what they need to do for people with dementia. And this has been accepted through the Ministry of Social Justice and Empowerment. Now, dementia was not the only problem. Depression was also there. And so we developed this program called DIL. And I'll tell you a little bit about DIL, the DIL initiative that we had. So this was the whole focus was trying to help elders help themselves. And it was how we can prevent depression in older people. Now, this is just outside. We have Goa has a lot of bars all around the place, and around our health center we had this bar that said Goa's like a fridge because everyone just chills out here. True, but then there are also some people who are having a problem, and the elder age group is at a high risk of developing depression, and so we need to kind of detect this early and be able to address that. As far as mental health is concerned, there is always the low resources as far as manpower is concerned. So we try to train lay health workers to be able to do this kind of intervention. Again, the same thing what I did with dementia. We try to get lay health workers to be able to reduce or prevent depression in older people. So we had taken in people who didn't have depression. And we did a lot of formative work initially. So, even when you do something in a community, you need to do this kind of needs assessment. So we used that theory of change workshops. We had in-depth interviews, focus group discussions. We spoke to community leaders to see what the problem was and what they think the solutions could be, and how we could have an integrated program. One person delivers the whole thing. It's not that they have to go to 10 people to be able to get the service. And we also did a lot of research, and we came up with a systematic review that showed that BBTI, which is brief behavioral therapy for insomnia, you help people sleep, and 2, which is called problem-solving therapy, was a method to deal with people with dementia. It's very interesting on how we did the pilot study and what the pilot study taught us, because I felt the pilot study was very challenging and very interesting. The outcomes very interesting. But as a result of it, we felt that engaging older people in a talk session, when you go to their house and say, okay, you want to do something for them, okay, will I get tablets? So they want to know. We have been brought up thinking that a medical person has to give us a tablet. If you don't give me a tablet, you're not giving me anything. So you're not done anything. So you need to be able to help them understand that the counseling and helping them take charge of their life and taking decisions is an important aspect of their life. So helping elders help themselves is all about that. We kind of help them understand through pictures. We came up with flip charts because we felt that engaging them in the talk was sometimes we finding it difficult. So pictures help them, and we made it very interactive. So they see the picture and they say, what do you see in this picture? And then they would explain something, and then we would hit there. Or we tell them a story like, okay, sometimes you fall down a ditch, but you need to get up from there. You need to find out stairs. You need to find out the steps that work for you. So if you have a problem and you're down, you need to come up by using these steps. And I will tell you how you can come up with it. So the problem, they would break up and come up with a solution, and we will come up on a good plan of action on how they will deal with the problem that they're having. So these are in older people who have depression. So we're visiting their houses. They had sub-threshold depression, and we help them use problem-solving therapy. Again, this is Professor Reynolds, who had come visiting some of the families around with us. And this is a team at our sub-center, and again, visiting some of the families. So, for example, here they would identify a problem. You can see here, as Dr. Ranjan mentioned, daughter-in-laws are sometimes the perpetrators of the abuse against older people. That is a huge problem. And even in our qualitative studies, we found that many of the older people speak about daughter-in-laws as having a problem with the daughter-in-laws that's causing a lot of stress. So it is like the shadi ke laddu khaye pachtaye na khaye pachtaye type of thing. So people who are living with the family complain that the family members are troubling them. People who are not living with the family are complaining that there's no one to look after them. So both ways it works. So we kind of need to help them deal with the issues that they're having. And first step is to identify the issue. The second step would be to find the possible solutions to the problem. And it could be anything like doing yoga and physical activity. We found to be a very good intervention for them. So we got people to be physically active, get out of the house and go for a walk, meet people. That was, we found to be very useful. We help them understand the comorbidities they have. So understand that diabetes fully. It is not like diabetes means you need to take a tablet, but what are the complications? What can happen? What has happened to you? And they would relate to many things that we are talking. So again, it was there on the flip chart. We don't burden everybody with the information, but in case they had diabetes, we would turn to the page that teaches them about diabetes and managing diabetes. So again, this was a randomized control study, and we had 2 arms of almost 90 people each. And we did the analysis, and we would do the evaluation at 3 months, 6 months, and at 1 year. And here is you can see the incidence of major depression in the 2 arms. 4.4% in the DIL arm, the intervention arm, about 4.4% of the people had depression at the end of 1 year, whereas the care as usual, there was 14% of people who had depression at the end of 1 year. And so this was a significant difference between the 2 arms. But if you want to see it in the form of pictures, we did the GH2 monitoring at 3 months, 6 months, and 1 year. And you can see immediately after the first intervention, there was a huge difference. The scores had dropped immediately. After a very simple visit, educating people, telling them to take care of their own health services, health problems. And it's not only health problems, social problems, financial problems, getting them connected to the social welfare to get their pensions. If they had a problem with sleep, how to address that. So take one problem at a time, split up the issues that can help you solve the problem and try to go ahead with it. And then leave it to the person to deal with the problem. So they took care of themselves for 1 year. At the end of 1 year, so you can see the confidence intervals do not overlap, and it was a significant difference right throughout the study, that we managed to prevent depression in these people. There were secondary outcomes. We did the WODAS, which was showing the functional status of people. Cognitive status, we did the Hindi MMSE. And this is something I probably need to highlight, because making a diagnosis of dementia sometimes could be a little tricky, because if you use the MMSE, which is, it needs to be culture fair, it needs to be education fair as well. So the original MMSE, which is the English version, had questions like, spell the word world and spell it backwards. So this concept of spelling is not there in most of the other languages, so we could not use those questions. And this has been thought of by Dr. Vijay Chandra, who did a study in Ballabhar and AIMS, and came up with the Hindi version of the MMSE, which is an adapted version. It is not a translation, it's an adapted version of the original MMSE, which works very well for the low educated people. And the Hindi MMSE is now translated into English, but it's still called the HMMSE. And it's translated in many languages, which could be used. And I feel that's a useful tool. But really don't go with the MMSE alone. You need to use your clinical judgment, because some people can have a very low MMSE score. Less than 24 is considered to be problematic, and the person could have a cognitive impairment. But some people could have a score of 20 and yet not have dementia. And at the same time, some people can have a score of 26 and yet have dementia. So you need to be able to use your clinical judgment, speak to the caregivers, and make a diagnosis. But the point I'm making here is we did secondary outcomes, but we didn't really see an impact, a huge impact on dementia or even on the functional ability. But we saw an impact on depression. So maybe following up these people further on might have shown us some kind of benefit. There were 24 people who were hospitalized during the study. And you would think that, I would say, in the intervention arm, there were people who were hospitalized. No, in the intervention arm, in fact, more people were hospitalized. It is just that people would take care of their health because of the intervention. People would say, okay, I need to do something. It was a very positive outlook. I can deal with my health problem. If I have cataract, I'll go and fix it. So 19 people, around 20% of the people in the intervention arm had hospitalization, whereas 5 people, or 5.6% in the care as usual arm, had hospital interventions. Though we were stunned with it initially, but then we realized that it is part of the intervention that we actually, people got ahead and solved the problem that they had by using problem-solving therapy and this. So it was a full team. At the end of it, excellent results. When it was a blinded study, and so when we unblinded the results, we knew there were 2 arms, and we knew evaluation in the 2 arms, but we didn't know which arm was getting the care, and it showed wonderful results. I'm very happy with the results there. And this is again, there's the International Consortium for Prevention of Depression, and of which I'm fortunate to be one of the members of that. But it didn't end there, and we had to do something for other older people who had depression, dementia, and other physical ailment, and the COPE program that I mentioned about. So we're fortunate. As I said before, just fortunate to have opportunities knocking at my door, and I open the door every time they knock, and get things done. And we sat at the WHO and came up with the guidelines on the ICOPE program, which I will share with you later. But the whole idea again is to improve the intrinsic capacity of people, and Group 3 has worked on that very well to improve the functional ability, address the issues of environment that could be a problem to them. So put some healing, etc., would be useful. So locomotor problems, how will you deal with it? What guideline says you can help people do exercises. Zumba, for example, is useful. As I said before, there is a lot of scope for exercise or for research to be done over here. What is the effect of yoga, for example, on trying to improve strength of older people? There is a scope for you to do that kind of research, and would be something that the country would be interested in, the government would be interested in doing that kind of exercise or research. Validity or vitality or nutrition is a problem, then nutritional supplements. And what we tried out over here is trying to give them a powder of a mixture of ragi and other millets, which would give them additional supplements that we could add this powder to, either have it plain or could add it to the food that they're eating to give them the additional micronutrients, etc. Cognitive decline, cognitive stimulation is found to be a very useful tool to deal with that. So keeping people engaged and socially engaged, or solving things like crossword, etc., would be useful. Psychosocial interventions, again, what I spoke about for the daily intervention, etc., was seemed to be useful. Sensory, do a visual assessment, do a hearing assessment, and get the cataract operated and get the hearing aid given to the people early. Do this earlier on because, as I said, it leads to other complications. Long-term care, we trained people running old age homes. There are a lot of assistive devices that can be done. The WHO has a program called the Be Healthy, Be Mobile program, wherein they do a lot of outreach through the mobile activities. There are programs for M cessation for tobacco, stopping tobacco, M diabetes program for diabetes. Then there's an NCD program, but also there is a program called the M aging program, which is meant for older people, and they are keen on working. They've already worked on the guidelines, what needs to be the contents, etc. So it is being tried and tested, and soon people will know about that. Again, I mentioned about the programs that we have, which are excellent, but we just need to get it into practice. So this is all that I would to share about our work. I think over to Dr. Archis. I know we're running short of time, but Archis, for the next presentation. Are you all okay with, I know since we started a little half an hour late, if we wind up by 5:30, is that our target,
Yes.
Dr. Archis?
Yeah, that we should ask the audience. We have two questions also. There are two questions that could be taken up. And Dr. Bodhi, what is the first step in building a team for geriatric care? Identifying needs using standard protocols. So those are two questions from her. And earlier we had one question from Dr. Biplab regarding intrinsic capacity. What does it mean?
Yeah, so I kind of mentioned that in the initial slides. What intrinsic capacity means is our capacity to walk. So, whether we can walk, whether we can remember things, whether we can see, whether we can hear. So this is our intrinsic capacity. Now, to be functional, there are two components that are important. One is the intrinsic capacity. So we should be able to walk, we should be able to hear, we should be able to think. Two, we need to have an environment that helps us to be functional. So if you're walking slowly, there is a possibility of you falling down, but if you have an environment that is slip proof, that has railing, you can do a lot more. You will see the story of Nora, and you'll see the second part of the video wherein there is help provided to Nora, and we can actually change by trying to address the issues of intrinsic capacity and changing the environment. Now, in an Irish community, a lot more is done. There's a lot more technology. You can, if you have to climb up steps, you can have some kind of a gadget that will, you can just sit on the chair and the chair will take you up. You know, these things are there, working there, may not be available very easily over here, but there are other things that we can do over here. But we need to understand two aspects: improve intrinsic capacity and improve the environment. So that's one thing. The other question I kind of missed out. Okay, how will you build your team? Yeah. So that again, it depends, because it's easy for me to say you build a team. You need to have a physiotherapist, you need to have an occupational therapist, you need to have a psychologist, you need to have a medical officer and geriatrician who's going to sit together and discuss this, and a nurse and a link worker. But are you going to have them? It's very difficult to have one community health worker in a primary health center. You don't have the basic level functionaries. So we have to make the WHO has come up with a module. Actually, it's going to come up with the first part of the module is already ready. In fact, I've shared it on the group, the one that Dr. Day has written. Dr. Day is a geriatrician from AIMS in Delhi, and he's done pioneering work in aging. And so they have a very easy to understand module, and things like counseling, etc. All the details are provided over there, and you should be finding that very useful. So that module is to train the healthcare staff at the primary health center to be able to provide geriatric health. So the nurse that is existing there, the medical doctor can do that. I would only think we need to have an additional link worker, somebody who is especially going to link them, follow up on those patients, which cannot possibly be done by the existing staff because they have their own jobs. So a link worker will be able to ensure that the older person comes and ensures the care. So in addition to that, if you have community rehabilitation center, nothing like it. You know, if you can really push for that, get the and the program, by the way, has this in plan. There is a plan. There is a budget. You can buy equipment for physiotherapy, etc., at your health center and try to develop this thing. It all needs your leadership to try to push for it and find out where the budget has gone and where the money has landed, and get it into action. Initially, I tell you, when the program was launched, there was a lot of activity. So there was a lot of monitoring. It was being monitored by the ministry, and so you had to report on a regular basis, weekly report of how many people have come to the center and what's happening and what is the progress. But then it kind of fizzled out, which happens with many programs. And the issue there is leadership. You just need to push for it. Once somebody tries to push for it, things fall in place. Next.
Right. So implementation has been a challenge. Yes, if the audience permits us, we can go for another 15 minutes to listen out to Dr. Ranjan. She has an interesting talk. Shall we push till next? Is that okay?
Yeah. Badil, can you share the presentation?
Yes, I will share, ma'am.
Dr. Amit, you have done very inspirational work, and I derived a lot of inspiration from your work, and I hope to do a part of it in our setting. Like we at least we can make an effort to do what you have done, even a bit of what you have done in our setting. We'll try.
So, you know, what I've done is I've actually motivated other people to do things. So even if I say the memory stuff, I don't do anything over there now. They just run it. I just educate seniors on what they need to do, and the program runs on its own. And yeah, so
self-sustainable models you have developed.
Yeah.
You have developed self-sustainable models, which is actually a goal in public health. We need to have more self-sustainable things.
Correct.
Right.
Hello, ma'am.
Yes.
It is aging with grace now.
Aging with grace. Yes.
Okay.
Yes.
Okay, ma'am. I'm presenting right now. Yeah.
Yes. So I'll start this presentation with a story. A very popular story, and we all have heard this story many times. The story of Gautam Buddha. When Gautam Buddha was 29 years old, he encountered for the first time in his life an old man, a deceased man, and a corpse being carried to crematorial grounds, and that jolted him out, and he actually wanted a solution for that. He was jolted out. He was shocked to see that state of human life, and he left his dynasty for the jungle, and rest is the story. And so what Gautam Buddha was doing, was he trying to prevent old age, or he was trying to run away from death and old age and disease? No, his whole objective was to reduce the pain and suffering that we attach with getting old, dying, and disease. So historically, from these stories, there are many songs, and the way in our literature, we connect old age, disease, and death with a kind of negative connotation. So we ourselves are also afraid of getting old and dying. So the very first thing that we need to understand is getting old and dying really painful? Badal, next slide. So this negative connotation that we have woven around aging and death has to be challenged. So this as we grow old, we tend to be more confused, depressed, and unhappy. Is it true? Do you believe it? Most of us may be nodding in positive. So I went through some research, and I was also myself surprised to get those studies, which are a kind of myth busters. The myths they have those we have carried since so long. Badal, next slide. Badal, next slide. Yeah. So this is a very important study. Back. Previous slide. Yeah. This slide. So what we can see in this slide, when we start out young, when we are 18 years of old, 18 years old, we are very happy, we are very optimistic, happy, enthusiastic. And then what happens till we are 50 years of age, our happiness drops because we are too much burdened with so many activities, taking care of kids, taking care of our elderly parents. So kind of sandwich generation, that kind of burden we experience. But as we grow old, it's a U-shaped turn. As we move towards 74 and 80, again, we start experiencing happiness. We start experiencing joy of life. So this is U-bend of life. And why this happens, there are many reasons thought about this kind of U-bend of life, where happiness actually dips in when we are 50, but it actually goes up. So when we are happier as we grow old. Next slide. Now this second slide. We all have been believing that we get frail and our immunity wanes as we get old. But this research has also challenged that. So what this research says, that our immunity increases by 20 years of age. At 40 years of age, it again dips down, but it started growing up. And at 50 years of age, our immunity is at its best. So it means that a 50-year-old person has the number of infection he experiences is not even half of the number of infection a 20-year-old experiences in his life. So immunologically, we are much better as we grow old. Next slide, Badal. Next slide. So yes, so we as we grow old, a lot of skills like our verbal skills, our vocabulary, our communication skills, lot of skills actually improves as we grow old, because a 20-year-old person may not be having that pool of skills, that knowledge as a 60-year-old person. So as we grow old, actually we are getting happier, we are getting wiser, and we are getting stronger immunologically. So when next time we look at an old person, we need to think he may be more smarter, more wiser, and more stronger than what we are. And we need to change the way we look at the older person. Because when we change that attitude of looking at older person, the same attitude we will be having for ourselves when we will be getting old. And that is very important to have a positive attitude of looking at ourselves. By the next slide, we have been knowing that if we call someone intelligent, many times he becomes intelligent. If we call someone a fool, he becomes fool. In the same manner, if we tell an elderly person he is weak, he is frail, he can't do things on his own, he may internalize those messages. So we need to change the messages that we are giving to our elderlies. Now, in terms of productivity and social contribution, the next slide. So when it comes to productivity and social contribution, what do you think? How an elderly person, 60 plus, can contribute and be productive? Now, what we have been taught in dependency ratio says that below 14 years of age and above 65 years of age, we are actually dependent. The people are dependent, and that's how we calculate dependency ratio. So dependency ratio in one way deciphers as if 65 plus people are dependent, they are not contributing financially and socially. But there are studies which has proven otherwise. Many older people continues to make a social, economic, cultural contribution. In Australia, 30% of older people participate in voluntary work, which amounts to $2 billion to the economy. Caregiving labors of grandchildren to national economy has estimated at $74.5 billion. 1 in 5 children is cared by grandparents. The mothers present in this group, how many of us, our children being cared by our mother-in-laws or grandmothers? So we all are aware that elderlies are contributing immensely to national economy. Next slide, Badal. Now there are other studies that actually we get old, our life satisfaction improves, our emotional stability, a sense of emotional well-being, they also improve. For most older people, aging could be a positive experience and satisfying stage of life. Next slide. Next slide. So aging gracefully, Badal, next slide. So aging gracefully has to has 4 components: physical level, mental level, social level, and spiritual level. And we all are aware, I won't get into detail like how to physically take care of this. We have WHO guidelines of exercises. We have WHO guideline for nutritional intakes. Just for knowledge, do you know who is oldest marathon runner? Just think about it. Next slide, Badal. Next slide. So these are the guidelines for physical exercise to prevent cardiovascular heart diseases. Next slide. Yeah, so the oldest marathon runner is Fauja Singh, who is 103 years old. He's born in India, and he completed marathon in Hong Kong in February 2013. Next slide, Badal. Now there are certain things like walking, yoga, tai chi. Dr. Amit also has mentioned that these things are important, and there are actually many studies which has proven that how yoga helps in aging gracefully, how gentle mind-body exercises actually bring about a balance between your sympathetic and parasympathetic system, and how they help in aging gracefully. Next slide. Next slide, Badal. Badal, next slide. Next slide. Next. So when it comes to cognitive health, as we age, there is certain part which is not so negative. Like as we age, there are decreased free recall memory, decreased processing speed, but vocabulary and general knowledge, it either increases or remain unchanged. So it's not like the cognitive skills always decline with age. And earlier slide we have seen that a lot of skills actually improves with age, and gradually after 70 they may decline a bit towards end of life. Next slide. Now, there are many centenarian studies have been conducted. The earlier centenarian studies have been conducted in European countries because European countries were the first to experience this aging phenomena. So all these studies, I have pulled the data from many of the studies, and the characteristics possessed by those centenarians who have completed 100 years of life are they were found to be extroverts, they were emotionally stable. Social capital is one thing. Now we are focusing so much on exercise and nutrition, but there is a phenomenon that is emerging that uh, people of very young age who are fitness freaks, and they are also experiencing myocardial infarction. That is making researchers look into the factors which goes beyond physical exercise and nutrition. What is making that difference? Why they are experiencing myocardial infarction at such young age? So there are studies which has been conducted, and it was found that it is social capital that is the major determinant of improving your life. One of the favorite book, my favorite book is Dean Ornish, Reversing Coronary Heart Disease. He has very beautifully mentioned, Dean Ornish, that vertical integration and horizontal integration is so much important for our health. So what does it mean by horizontal integration and vertical integration is vertical integration is the way we communicate to the higher consciousness. We may call it God or universe or cosmos. So how is my relationship with that reality? And how is my relationship? Horizontal integration is how do I deal with my fellow being? How much I'm connected to people whom I come across on my day-to-day life, and how connected I am to people, and how much connected I am to the God. So this social capital and spiritual capital is actually a defining thing when it comes to healthy aging. Then intermittent fasting. I think most of us are aware about this concept, intermittent fasting. And there is so much research, evidence is also emerging. Like how intermittent fasting, there are types of intermittent fasting. There could be 16 hours window that people follow, or there is just fruit fasting that they do 1 or 2 days. So this type of intermittent fasting actually stimulates your immunity system. So there are many articles on this as well. People who are centenarians who live long actually are the people who are engaged in some kind of purpose. They have found passion in their life. They're passionate about something. They're actively contributing to something. So these are the characteristics, and of course genetics. So these characteristics we can divide into genetics, environment, and personal. Next slide. So these centenarians, their characteristics are they are less likely to get anxious. They have some religious belief, spiritual practices they are doing. They take things a day at a time, accept health problems. Now, accepting health problem or accepting old age is so important. See, we all are living in a aging era. We are living in a where demographic transition is taking place. We are living in an aging community, and we are also living in an era where market is flooded with anti-aging products. So this is so contradictory. At one pole, we are actually aging, and another pole, we are consumers of that anti-aging cosmetics or products. So it represents a conflict. We are aging, but we are not willing to accept that aging. So that acceptance for aging and death is so important. They are open and they are less sensitive. I think less sensitive means they're less vulnerable for emotional things. Next slide, Adil. Now, these few things I have added, like I have already mentioned, like yoga and meditation helps in improving the expectancy of life. Now, meditation, there are a lot of studies about meditation. Few studies say that meditation, who are meditators, the cortex, the frontal cortex is thick, and the corpus callosum also show certain changes in meditators, which helps in regulating emotion in better way. So there are a lot other findings like how the central nervous system responds to meditation and helps in healthy active aging. Now about journaling, I would like to mention journaling is, it seems very simple thing, and in normal plain language, journaling is nothing but diary writing, the way we write our diary, but how it helps in improving lifespan. So there are certain studies on journaling as well, that if you write your experiences 20 minutes a day for 5 consecutive days. So there are studies which have proven that it reduces your stress level. And how it helps, like the way it has been explained is, when you are writing something, you are actually using your hand, and hand is very rich in muscles, and these muscles are represented in frontal cortex. A bigger area in frontal cortex actually represents the your muscles in your hand. So by when you're writing things, you're actually stimulating a bigger area in your frontal cortex. And when you're regulating emotion, it also stimulates corpus callosum. So simple thing like diary writing, or we may call it journaling, helps in improving expectancy of life and building a positive attitude. Next slide. Badal, next slide. Yes, Dr. Amit has very well mentioned in his presentation that geriatrics. Do I have time? 5 minutes more?
Yeah, just Dr. Ranjan, probably a minute if you can wind up because Dr. Ajis has to speak next. So if you can just see, if you can summarize in
I'll take
minute.
which is 5 minutes, more 5 minutes. Yes. I'm about to, this is the second last slide. Okay. So pediatrics, the geriatric care start from pediatric care. So I just felt like to mention about Erickson's 8-stage theory, like how these are the 8 stages we go through in our life. And the one stage of life actually builds upon the previous phase, and that every phase there are certain challenge and there are certain conflicts. So from birth to 18 months, the conflict we are experiencing is trust versus mistrust. As a child, I depends on my parents and caregivers for food, for warmth, and for love. If those needs are met, I build a kind of trust in the world. But if those needs for love and basic needs are not met, then I may develop a kind of mistrust. So when I grow up, I may experience anxiety, frustration, and not able to deal with those kind of emotions. So from 18 months to 3 years is autonomy versus shame. So when we are in that age group, we are actually toddlers, and we are trying to do things on ourselves. We are trying to feed ourselves, we are trying to clothe ourselves. And if we are not allowed to do that, and we're not allowed to develop a kind of autonomy, even in sense of toilet training, if parents are very much critical of the child, and he's actually felt, gets into shame and doubt. So the child does not develop autonomy, self-esteem, and confidence, even as a grown-up person. The third stage is when it's a preschool age, when actually the child wants to do things on his own, when parents play with the child and they allow the child to be teacher, parent, or doctor, or salesperson, and parent choose to be student, customer. So this kind of games actually allow the child to develop initiative. If that is not done, that initiative is not built in a healthy way, the child gets into guilt, and that remains there as he gets old. And from 5 to 12 years is industry versus inferiority. If the child is allowed, is a school time for a child, and if the child is allowed to be industrious, do things on his own, excel in plays, music, dance, he develops an industriousness. He tries to do things on it. If it's not fulfilled, then the child may develop inferiority. Then from adolescent age group, it is identity versus role. So is that is the age. Adolescence is the age when the child, they are trying to develop a self identity. They are trying to differentiate themselves from parents and trying to understand what are their values and their beliefs. If they're not handled properly, they're not able to handle this phase properly. They either develop a very strong sense of identity, strong sense of self, or they land up in lack of sense of identity. Now, 18 to 40 years, most of participants are, I think, belong to this age group from 18 to 40 years. So the conflict for this age group is intimacy versus isolation. If you have gone through the earlier phases in a very healthy manner, if you have developed a strong sense of self, I may be happily able to share myself with others. I may develop intimate relationships with others. If I am not able to do that, I may feel isolated. That may give rise to loneliness, depression, and lack of purpose in life. Then for 40 to 65 years, it is generativity versus stagnation. So this is the time we are doing for others. We are generating things. We are contributing to our parents and our children as well. If I am not healthily, happily doing it, able to do it, then I may experience stagnation. I may get stagnated. I may get stuck over there. Now, if I go through all these phases positively, above 65 years of age, I may experience a sense of integrity, a sense of satisfaction. If those needs are not met, if those conflicts have not been resolved in a positive way, that elderly person may go through despair. So this is a very nice 8 stages where we go through, and we need to understand about this. All those who are actually dealing with elderly or dealing with adolescent or whatever age group we are dealing with, we need to understand these phases and these stages and the kind of conflicts we go through and help that age group in dealing with that conflict accordingly. Next slide. This is the last slide. So this is Panchaklesha. Like we talk so much about stress and so much problems, let it be in geriatric age group or in any age group, are related to stress. I was reading Patanjali Yoga Sutra and I came across these 5 causes of stress. I have never read anything so profound about stress. I have read so much about stress, but I found it very profound. So what Yoga Shastra says about stress, there are only 5 causes of stress in this world. There can't be 6th cause of stress. And they mentioned it like raga. Raga means attachment. Attachment means me and mine. Like it could be physical thing, outer thing, or it could be internal thing. So I feel so much attached with my external things, my position. It could be my family. It could be my car, my bungalow, material things, or family, or my position, whatever. So we have a sense of attachment, and that attachment creates stress as per the Yoga Shastra. The second klesha means sorrow or stress. The second stressor is dvesha. If I have a strong sense of attachment, proportionally I will also have a strong sense of aversion, which is called as dvesha. So raga and dvesha are proportional. If I have more raga, I will have more dvesha. If I have more attachment for my and me and my, I will have hatred for others. So I define that I and you borders very strongly. Then third stressor is avidya. So Yoga Shastra says avidya means ignorance. So as per Yoga Shastra, if I believe that material reality is the only reality, and I believe that all temporary things are permanent things, that is going to lead me to stress. If I deny spiritual reality and too much indulge in material reality, that will create stress. Then fourth stressor is asmita, selfishness, I-centeredness is asmita. And fifth is very interesting, abhinivesha. Abhinivesha means fear of change. So fear of getting old, fear of dying. So this kind of fear is known as abhinivesha. So Yoga Shastra has mentioned these 5 causes of stress, and I think this 5th cause, fear of change, or fear of getting old or fear of death, is very important when it comes to geriatrics. So what solution yoga offers is just being aware of these kleshas and working on it actually helps us alleviating that stress. And if we look at, by the next slide, if we look at the characteristics the centenarians possess, we can connect the dots. Actually, they are working on this panchaklesha. Though they are not aware about it, they are practicing it. They have found their purpose. They're more giving. So somewhere, though they haven't read it or studied it, but somewhere they're practicing it. That's why they have landed up there, like crossed 100 years and still healthy, still going. Badal, next slide. This is the last slide. So, Badal, next slide. So eventually we have to reach a point when we stop hiding our age and actually start bragging about it. Because those presentation and those studies were actually eye-opening for me too, when I realized that actually when we age, we get better on many things. We get better on cognitively, immunology improves, happiness improves. So actually we should feel happy about getting old and feel good about it rather than feeling sad about it. Next slide. Next slide. So I wish you happy aging. I wish you a journey, a fulfilling journey when we grow old happily and pass this world to the another world happily. Thank you so much.
Thanks, Dr. Ranjan. I think over to Dr. Ashish now, who's going to make the final presentation on leadership, which is kind of very interesting.
Yeah, I'll just have one slide presented, less than a minute to go. Please allow me the presenter rights, Badal. So just perfect. So I had a couple of slides, but I think that if we focus on this particular slide, it will make the maximum use. Using a systems approach to leadership in geriatric care or care for the elderly, integrated care for the elderly, we see that there are 4 overlapping circles. Now we need to excel in all of that in order to be effective and be identified as a leader. And this is for your own personal reflection.
Sir, your voice is low, sir.
Is my voice too low? Is it low for everyone?
For me.
Huh? Is it low?
It's okay.
Okay, right. So there are a lot of literature about individual effectiveness, your hard skills, soft skills, and there is a lot of ways in which we improve on that. Relationships and connectivity, ability to be creative, to innovate and improve, because we have clearly identified that there are not many interventions in this area, and there is a need to be very creative, go out of the way, be an outlier of sorts, and rapidly learn and build capacity. Now, this is both at the individual level and at the team level. Then broadly, there are 3 different aspects in which you can identify, you can intervene and be quickly identified as a leader in this field and be more effective also, drive change in the direction of your vision. 1 is by developing people. So you build a team or you empathize with a group of people and they start sharing your vision and you build their capacity. This is sort of mentoring. This is very difficult to do. But if you are an amicable person, congenial one, then you can definitely invest here. It's about knowing your own personality. The next is developing innovation. So we have been trained to some extent in this regard, especially in thought leadership. So we can take up research, which is very relevant, very pertinent to our own context, and build on those research questions, go on publishing, go on speaking on different forums, be very fact-supported, very factual, very evidence-based, and then be identified as someone who talks sense and is very precise. So thought leadership is one angle in which you can develop yourself. The third and the most important is by developing collaboration. Now, when it comes to system science, collaboration is most important. And the collaboration cannot be just with anyone. It has to be with leaders in the field. So leaders collaborating with leaders makes everyone a leader. And that is the most powerful and impactful way of doing it. So if someone is doing very well in the field, and if you are connected to that person, and you are also trying your best so that the other person that you're collaborating with values your friendship, then you are definitely on a trajectory to become a leader. And that kind of a collaboration should be sustained. So this particular dimension is something that you must very carefully choose, identify, and get invested into. The field of geriatric medicine is very young. We do not have many papers here. We do not have many teams operating here. So if there is a 10 by 66, or if there is a group which is working here, and you are associated with that group, with some passage of time, you tend to do good work, you tend to mobilize, you tend to build a CV, and you eventually rise. And especially when you are able to replicate certain information, certain evidence-based interventions in your small area of work. Now, this is the crux of all that I had prepared. Now let's skip all these slides. Maybe this one particular slide could be of interest because there were a couple of questions here. Now, are there any validated tools? Yes, there are many validated tools. In fact, studies on dementia, they do not use any single tool. So if you're planning to do any study in your area, try to use a couple of tools which go into different aspects and make the assessment more comprehensive. Activities of daily living and instrumental activities of daily living, these are the most commonly used ones, and they are also used in differentiating between MCI and frank dementia. In MCI, you do not, mild cognitive impairment, these are not actually impaired. Coming to clinical dementia rating, you can undergo the training and be certified. It's a difficult tool to apply, but then you can definitely earn a certificate. It's a free training. Addenbrook's cognitive examination, this one also can be freely, you can undergo a training and get a certificate for yourself. These are very nice tools, can be used, have been used in India. And coming to the other tools, there are several other tools. There is a full battery, neuropsychiatry battery, that is being validated by ICMR in hospital settings, have already been done. Community settings, of course, will be done. You can go and access the 10 by 66 website to see all the tools that they're using. Use some of them. Video lectures, video training modules are available on YouTube. Coming to clinical training, if you want to take up clinical training, we already had Dr. Kansal speaking about the PHFI training, but then the diploma in geriatric medicine from IGNU. This is one fantastic site that I found, National Institute of Social Defense from Government of India. Multiple small courses, not just for healthcare professionals, but for NGOs, non-health people can go and see those courses also. The postgraduate diploma in geriatrics, that's from CMC Vellore. This course has its enrollments open, and from time to time, currently it is not accepting applications, but soon they will have. And this costs about 75,000 rupees. It's a one-year course, and you can spend about 2 weeks or so taking care, actually doing clinical rounds in CMC Vellore under supervision. So you can start a practice around geriatric. You can start a geriatric clinic doing this course. Now, regarding leadership training programs, there are about 20 odd leadership training programs in India. About 12 programs that are very heavy on health management aspect, and 8 programs on health research. Now, Sangat runs a course on mental health leadership. Dr. Amit already knows about it. He is a mentor over there. He's a facilitator there, I guess. And you can check out their website. The Incline Leadership and Management Program, that is also a good program, conducted almost once annually. They have a prospective follow-up component there. There is there are several IHMR led programs, and PHFA also does a leadership program. Recently, Sangat, through its Bhopal unit, has started an implementation research in mental health program. So that one is also good. Very active on Twitter. You can follow developments there. Beyond all this, ethics is very important in geriatric medicine because this is vulnerable population. You can download the ICMR Ethical Guidelines 2017, and there is a section dedicated for handling ethics in vulnerable population, especially when it comes to legally acceptable representative, LARs, and consenting. So those are 2 aspects. Regarding the tools, of course, the tools have validity issues. You carefully choose which tool you want. Now, this is all in crux. We can play Nora's remaining video, and I guess that will be a good happy ending to our discussions this far. Let me take you back to Nora.
Here's how Nora's care might have been better coordinated. Evidence shows that if we identify older people at risk earlier and coordinate services better, we will reduce longer hospital stays and avoidable long-term care. In doing so, we will enable older people to stay at home longer. A key change is that we take a long-term approach to anticipating and coordinating older people's care rather than reacting to their needs as a separate episode of care each time they present to health and social care providers. There are many examples of good care evident around Ireland. GPs and pharmacists undertake reviews of medical and pharmacy needs every day. Home helps assist older people who need help with everyday tasks. Public health nurses monitor people's health and social needs on an ongoing basis. However, the problem is that even when these services are available, they are not sufficiently coordinated by a named person who is dedicated to working with older people and who can act as a point of contact that anticipates, plans, and coordinates care with the older person and their carers. Nora would have benefited from the care and support provided by a primary care team who could have carried out an early holistic evaluation of her health, including her social care needs. This would involve a multidisciplinary team assessment by professionals trained in older persons' care, such as an occupational therapy assessment to suggest modifications or aids to her home, physiotherapy to assist with walking, social workers to ensure supports are in place to keep her involved with her community. The primary care team would link with a specialist geriatric team if and when required. To coordinate her ongoing needs, Nora would have benefited from a case manager for older persons, who would have worked with Nora and her family to develop a care plan to meet her needs. This person would act as a point of contact and coordination, who helps Nora to access services early rather than waiting for a crisis to happen. If acute inpatient hospital care was needed, steps could have been taken to improve the likelihood that Nora would have returned home. These steps include a comprehensive geriatric assessment led by a consultant geriatrician and multidisciplinary team at the time of her admission. Admission to inpatient care on a specialist geriatric ward with a healthcare team familiar with managing complex healthcare needs in older people and with access to rehabilitation, and clinical staff with specialist older person knowledge, such as advanced nurse practitioners, working with a case manager in the community to coordinate Nora's future care needs. Working together, this team would have developed a longer-term care plan that would be agreed and communicated across hospital and community services and, of course, to Nora and her family. After hospital, access to practical services in the community would have helped Nora to live comfortably in her own home. These would include help with medication, shopping, and minor repairs. This snapshot of Nora's story shows how the development of an integrated care program for older people is a priority for our health and social care services. The team leading this program are meeting and working with health and social care professionals nationwide to plan how existing care can be better coordinated to benefit older people and staff working with them. This seeks to build on a shared local vision that builds a population-based approach to integrated care that is person-centered, planned, and coordinated. Find out more about integrated care services at www.hse.ie/Nora.
Yes, Dr. Amit, over to you.
Yeah. Thanks, Archis, and thanks, Dr. Ranjan, for that for the presentation, and thanks for everyone for staying on here. So I think to summarize, the whole aim is to help you understand that there is this concept of integrated care for older people, and it is there in paper. And the video that you have seen is in the Irish community. You may say, oh, this is too far-fetched for us and we cannot get there, but there's no reason why we cannot get there. But what we can do is to try to look around us and try to see how we can use locally available resources to be able to reach the people. Because very often the reason why we feel that we don't have enough, it's not that we don't have enough manpower. The whole issue is that in India, we say we have such a big population. So we have enough manpower. We just need to train them to be able to adjust their existing work to be able to build this outreach. So once you have a very clear vision in your mind, once you have the training modules that are necessary, once you know what evidence works, the evidence that shows that these things work, I think it's up to us as leaders to put things into practice and make things work. For example, the work that we did in dementia is part of the dementia action project, which is been told to the government that we need to integrate this through our wellness centers to be able to reach out to people. So very simple. It's not very expensive, but it requires training, it requires a sustained interest in that. So it requires somebody who's going to take the lead and try to push for these things. So that is the whole idea of this training. I think I just did a very good presentation on trying to. I was looking at when I was going through the slides that he was presenting. I was thinking that we have developed as leaders. We're not kind of trained in leadership, but when you look back, we have done all those things that he is put in the slide. And kind of, he said very clearly, try to connect to people who are working. So, you may realize that you are struggling with something, but that has already been struggled. Somebody has already struggled in that area and already found a solution. So don't sit there and try to reinvent the wheel. You're wasting your time. Connect with other people. And it will be a very useful thing when you try to build that team of like-minded people, and once you show that things work, then it is sustained. At the memory cafe that we have started works not because we told them that it works, but because the people who are working in that memory cafe find the benefit. They look forward towards it, and they come up with something new and try to better themselves. So that is how things can be sustained, and that's how we can actually reach out and ensure that everybody gets integrated care. So thank you all, and really thank Abhishek for this. He came up with a out of the blue kind of a workshop theme for us, and I kind of met these wonderful people as well. Not that I didn't know Ajus too well. He was we connected, and even with Ranjan we connected before, but then I didn't know them as well as I got to know them while we were preparing for this. And very good. The leadership they showed in this also was, I think, definitely I would appreciate that. And thanks to Badal and for shifting us here and there into different rooms. I can see it's a huge challenge. I would like a photograph of everybody. I hope somebody has done that. Everybody puts their video on and we click one photograph. So is that a kind of thing that everyone can do? Can everyone just put your your video on, and somebody can do a screenshot? Who can do the screenshot?
I can do the screenshot.
Okay, do the screenshot. And you can do something. You can do a B, not vaccinated, or whatever. Plan what you want to do.
Do we have
done?
that?
Yes. Integrated care, and wish you all the very best. If anyone wants to have any questions in mind, just before we wind up.
Yeah.
Any questions? The no questions means we have done a good job, or we confused you totally. I am a very positive person.
Everything's very clear.
Sir, actually, it's very good experience to listening to you all. Even though it is small group, you have shared your experiences with great patients. Thank you, sir. We'll start somewhere.
Thank you very much.
Thank you so much.
Thank you. Thank you.
Bye.
Yeah. Bye, everyone. Enjoy yourself.
Hello. I just want to express my heartfelt gratitude to our facilitators, Amit sir, Ranjan ma'am, Ashit ma'am sir. So thank you so much.
And to you, Badal, as well. Wish you all the very best.
And pardon me if I have taken some time here and there. Yeah.
Thank you, Badal. WebEx is very challenging all the time, so there is a lag. Can't help. Thank you so much.
Thank you. Bye bye.
Thank you, Dr. Ranjan. Thank you, everyone. Thank
you.
Thank you.
Bye.
Bye.
Bye, Badal. Thank you. I can end the meeting. Shall I end the meeting or shall I leave the meeting? Badal?